During this morning's hearing on the youth mental health epidemic, we're going to have an opportunity to build on last week's superb discussion with the Surgeon General, Dr. Murthy. Last Tuesday, Dr. Murthy told us that mental health problems often show up first when we have people who are very young, but the average delay between the onset of mental health symptoms and the beginning of treatment is actually 11 years. Those are, in the Surgeon General's words, 11 long, confusing, isolating, and painful years. This obviously is a number worth 1,000 words. And more than anything, it says that America's approach to mental health care is way out of whack. And it starts failing America's young people early on. So several priorities for today. Let's focus on how mental health care for young people starts much earlier. Earlier screenings, earlier interventions, earlier discussions with primary care doctors. There's also a need to step up mental health efforts in schools and in our communities. Those are also places where trained professionals can get the symptoms right from the outset and refer young people to skilled practitioners when necessary. At present, we get told again and again that school counselors are overwhelmed, community-based programs are too few, and referrals are inconsistent. Mental health care simply doesn't start early enough, and it's not reaching young people where they are, especially kids in rural areas. Second, our country must have better crisis care. The 11-year treatment gap is a sign that young people are struggling, going without the treatment they need and heading on a path to crisis. In addition, America's mental health system too often fails the young when they're in crisis as well. The evidence shows that the pandemic has driven a shocking increase in self-harm among young people. Suicide attempts among young teen girls resulting in hospitalizations recently jumped more than 50%. Far too many of these young people in distress are spending days or even weeks boarded in emergency departments. For the bulk of the time, they're probably alone. Imagine colleagues feeling a sense of extreme isolation, clashing with chaos and commotion of the emergency department buzzing outside your door. Just yesterday, I spoke with a group of Oregon healthcare practitioners and physicians who told me they were concerned that in many of these crisis situations, young people who end up in the hospital emergency rooms aren't even seeing practitioners with those who have training in mental health. The emergency room is no place for a child in crisis to spend day after day, but it's all too common. Young people simply deserve better. Third and finally, solving these problems is going to require creativity from the public and the private sector. The Children's Health Insurance Program and Medicaid, which is the largest single payer of mental health care for young people, can play a key role in sparking new solutions. These efforts will be essential to make sure that mental health is treated with the same consistency and focus given to physical health. The bottom line is no more mental health business as usual, because business as usual is failing too many young people at every single point, from the first sign of symptoms to the most critical moments of crisis. That's a lot for the committee to discuss today on these key issues. We're going to have a great panel, that I'm going to introduce shortly. I want to thank Senators Carper and Cassidy for heading up our efforts on youth mental health care. And I also want to commend Senator Stabenow for her years and years of work on behavioral health issues that are so important and that we'll build on. Now we'll turn to Senator Crapo for his opening remarks. Then we'll have introductions. And where is my friend Senator Crapo? There he is. Senator Crapo.
Thank you, Mr. Chairman. And thank you to our witnesses for joining us today as we discuss ways to respond to mental health challenges impacting children and adolescents across the country. According to recent reports from the CDC, the number of young people dealing with depression, anxiety, and suicidal thoughts has unfortunately risen during the pandemic, as social isolation has taken its toll on far too many children and adolescents. Although it appears the pandemic is subsiding and our return to normalcy may be imminent, we cannot ignore the lasting effects of the past 2 years on the social and emotional well-being of children. We should do all that we can within our jurisdiction to increase access to high-quality mental health services and reduce the causes of delayed and foregone treatment. While mental health issues affect people of all ages, children's needs are often different from those of adults, necessitating carefully tailored solutions. As this committee works in a bipartisan way to advance the conversation on mental health, we must not only identify the complexity and scope of the problems at hand, but also explore innovative, sustainable, and concrete policy solutions. I look forward to working with my colleagues on both sides of the aisle to develop meaningful measures to meet some of the nation's mental health challenges, including by expanding access to telehealth services, supporting our mental health workforce, and better integrating physical and mental health care services. Children can and often do benefit from services delivered by telehealth. While we often focus our telehealth discussions on Medicare, where the key access gaps and barriers remain, this committee should also prioritize clarifying and expanding care delivery options for children covered by Medicaid, regardless of geographic location. Additionally, we should work to maintain a strong mental health workforce with the capacity to care for all who need services. These efforts will prove particularly crucial as healthcare professionals burn out, steep regulatory demands continue, and other strains jeopardize long-term provider retention and capacity. We have clear opportunities for improvement at every level. I regularly hear from frontline providers, as well as state policymakers, seeking the flexibility to innovate and craft targeted local solutions to the challenges facing their communities. Their ideas and input will play a critical role in this process, especially as we look to bridge gaps in care, better integrate physical and behavioral health services, and promote value-based payment models that put patients first. If structured effectively, these reforms could prove game-changing populations of all ages, including young people. Finally, no conversation on mental health care reforms for children and young adults would be complete without input from those whom the policies intend to empower and support. To that end, Trace, thank you for your willingness to join us today to share your perspective. We have the opportunity to better support children, their families, and their providers by enhancing mental health outcomes across the United States. Moreover, we can and must do so while honoring this committee's strong tradition of member-driven, bipartisan, and fiscally responsible legislative solutions. Thank you to our witnesses for agreeing to share their expertise from across the continuum of care. They've provided invaluable service during these unprecedented times, and I look forward to hearing their testimony. Thank you.
Senator Crapo, thank you for a very helpful opening statement. As you noted, we're going to do this in a bipartisan way. There's an awful lot of common ground here, and I'm especially appreciative that you zeroed in on telehealth, because the Finance Committee is especially proud of the telehealth contribution we made at the beginning of the pandemic. During those early days, the Center for Medicare and Medicaid Services, headed by Seema Verma, was trying to figure out how to proceed. And to a great extent, they took the telehealth provisions of the chronic care law that was written in a bipartisan way in our committee. So I appreciate your zeroing in on telehealth issues, and we are certainly going to build on them in our work this year. And also, thank you for giving a little bit of a send-off as we move to introductions to Trace Terrell, because he is one of our own, a student from Lapine, Oregon, a mental health leader and an advocate in his community. He's volunteered with Youthline, a peer-to-peer youth crisis service based in our state that receives 27,000 contacts each year from young people across the country. Youthline is provided by Lions for Life, a nonprofit dedicated to suicide prevention and mental health support, and Oregon's home for the National Suicide Prevention Lifeline. Beyond Youthline, Mr. Terrell has advocated for youth mental health through a number of other organizations, including the National Mental Health Advisory Board, supported by Wellbeing Trust, Young Invincibles, and Active Minds. A high school senior, because I'm on the intelligence committee, people sometimes tell me important little items about our guests, and I recently learned that Mr. Terrell has been accepted to Johns Hopkins University, and we all want to extend him congratulations for that great achievement. With that, I'm going to turn it over now to my colleagues to introduce witnesses that they have worked with and are very proud of. Senator Craig Casey will introduce Dr. Tammy Benton from the Children's Hospital of Philadelphia. Senator Hassan will then introduce Ms. Jody Lubarsky from Seacoast Mental Health Center in New Hampshire. And then Senator Cardin will introduce Dr. Sharon Hoover from the University of Maryland School of Medicine, National Center for School Mental Health. And then we will hear their testimony. Senator Casey.
Mr. Chairman, thanks very much for this opportunity. I'm pleased to introduce Dr. Tammy Benton, and I appreciate Dr. Benton's expertise at this hearing today, in addition to her lifelong commitment to serving both children and families. Dr. Benton is psychiatrist in chief, executive director, and chair of the Department of Child and Adolescent Psychiatry and Behavioral Sciences. She's clinical director of Child and Adolescent Psychiatry and a psychiatrist in the 22Q and U Center at the Children's Hospital of Philadelphia, which we often refer to by the acronym CHOP. She also serves as president of the American Academy of Child and Adolescent Psychiatry and an associate professor of psychiatry at the Perelman School of Medicine at the University of Pennsylvania. Dr. Benton also serves on the board of the Juvenile Law Center, which advocates for children and child welfare and the juvenile justice systems. Her expertise spans pediatric depression, suicide, and anxiety, particularly for minority youth and those with chronic diseases, as well as our mental health workforce shortage. So Dr. Benton, thank you for being with us today, and thank you for all you have done to support families long before and throughout this pandemic. I look forward to your insights today.
Senator Casey, and we look forward to hearing from Dr. Benton. Senator Hassan is here to introduce Ms. Lubarsky.
Well, thank you so much, Chairman Wyden and Ranking Member Crapo, for holding today's hearing on protecting youth mental health. It is essential that we get our children the mental health support and resources that they need. And I'd like to welcome a Granite Stater who is with us today to serve as an expert for today's hearing. Jody Lubarsky is the Vice President for Clinical Operations, Youth and Family Services at the Seacoast Mental Health Center in Portsmouth, New Hampshire. She has a Master of Arts in Mental Health Counseling and is a licensed clinical mental health counselor. At the Community Mental Health Center, where Ms. Lubarsky works, she oversees the evaluation and treatment services for children, adolescents, and their families. These services include psychotherapy, psychiatry, community-based behavioral supports, targeted case management, substance use disorder treatment, 24/7 crisis intervention, and post-intervention services to schools and communities affected by suicide and loss. To say she is at the front lines of some of the toughest battles our children face would be an understatement. In her role as vice president and as mental health counselor, Ms. Lubarsky provides support to young people who are experiencing mental health challenges. And she has seen firsthand how the pandemic and a shortage of mental health services has increased the number of patients in her center. In fiscal year 20, the Youth and Family Services team at Seacoast Mental Health Center provided more than 33,000 services. In fiscal year 21 alone, it provided more than 41,000 services to children and families, a 25% increase. The number of patients seen in fiscal year 21 was almost 13% higher than in the previous year. In response to the wave of children and young adults requiring services, Ms. Lubarsky has worked on innovative programs in New Hampshire that have been integrated into places like our schools and our summer camps. Given her extensive experience and expertise, she'll be able to speak today about the challenges facing our children, the critical programs that she's helped to develop, and the persistent barriers that limit access to mental health care. Jody, thank you for being here and for your work on behalf of New Hampshire's children and families. I look forward to hearing from you today. Thank you, Mr. Chairman.
And thank you for all your help for this hearing and for making sure we could have Ms. Lubarsky, and we're looking forward to working closely with you every step of the way as we tackle this issue. Senator Cardin is here to introduce Dr. Sharon Hoover.
Well, thank you, Mr. Chairman. Let me thank Senator Wyden and Senator Crapo for their leadership on this issue and on so many others, bringing us together to deal with a critical problem. I first wanted to acknowledge, Trace, congratulations on your acceptance at Johns Hopkins, located in Baltimore, Maryland. Very proud to have you in our state. But I'm proud to introduce a fellow Marylander, Dr. Sharon Hoover. She is a licensed clinical psychologist and professor at the University of Maryland School of Medicine, Division of Child and Adolescent Psychiatry. She's also co-director of the National Center for School Mental Health and director of the Center for Safe Supportive Schools within the National Child Traumatic Stress Network. Dr. Hoover has led and collaborated on multiple federal state grants and is currently co-leading 2 large randomized trials of school mental health efforts. Since 2004, she has worked with the National Child Traumatic Stress Network, Treatment Services Adaptation Center for Resiliency, Hope, and Wellness in Schools to train school district and school leaders, educators, and support staff in multiple tiered system of support for psychological trauma. Dr. Hoover is a certified national trainer for the Cognitive Behavioral Intervention for Trauma in Schools program and the support for students exposed to trauma program. Last year, she was kind enough to join a constituent event I hosted concerning youth and COVID-19. And I know that Dr. Hoover's input was extremely helpful to my constituents, and I know she'll add greatly to our discussion today. Welcome, Dr. Hoover.
Thank you, Senator Cardin, and for your years of advocacy in the healthcare area for vulnerable folks in Maryland and our country. So thank you all, colleagues. And Mr. Terrell, we're glad to have your voice coming from Lapine, and please proceed.
Thank you, Chairman Wyden, Ranking Member Crapo, and the other members of the committee for the opportunity to represent the youth perspective as it pertains to mental health. My name is Trace Terrell. I use he, him pronouns, and I'm a 17-year-old from Lapine, Oregon. Before I share more about myself, I would first like to tell you some things I have heard from teens across the country. 4:07 p.m. I just need someone to talk to. 4:37 p.m. My dad hit me, but you can't call the cops. 5:23 p.m. I need therapy, but my family can't afford it. 8:07 p.m. I just lost my dad and I can't stop crying. 6:42 p.m. I want to kill myself. These are just some examples of the many conversations that I respond to as a volunteer with Youthline, a free, confidential teen-to-teen crisis help support hotline located in Oregon. Whether helping someone navigate complicated feelings about their sexuality or working with others to develop comprehensive safety plans, I spend 3.5 hours every week responding to a variety of mental health challenges experienced by teens across the country, with an emphasis on the fact that no problem is ever too big or too small. I became involved with Youthline during my freshman year of high school. As someone who struggled with depression, suicidal ideation, eating disorder behavior, and anxiety throughout middle and early high school, I, for the longest time, believed that no one could relate to my experiences. However, as I became more involved, I realized that my challenges were a microcosm of public health issues that affected hundreds of thousands of teens across the country. As more and more teens start to have conversations about mental health and engage in help-seeking behaviors, the need for expansive and intersectional mental health efforts has never been so needed. So, what can we do to address the youth mental health crisis? 1, we must centralize our efforts in schools. From my experience and many of my peers, mental health efforts in schools are lacking. Day after day, I hear my friends and those on the line voice how inaccessible school counselors are due to being overworked and overloaded. This is an especially difficult challenge for the many teens who rely on school mental health professionals for crisis care. We have to address this staffing crisis. We must also create a streamlined approach to free mental health screenings and referrals. At my school, 4 of every 5 referrals to external resources are not carried out. Let that sink in. 80% of referrals go nowhere. Someone who needs help should receive help. Last, we need a comprehensive and standardized mental health curriculum. All students should learn about engaging in real-world help-seeking behaviors, developing systems of self-care, and supporting our friends with mental health struggles, because statistics show that we turn to each other before anyone else. 2, we need to address the pressing challenges that young people continue to face in accessing mental health care. While I'm no expert in policy solutions, I am someone with lived experience. I know what it's like to be a teen today struggling with mental health, and I know what it's like to offer support to teens in crisis. On and off the lines, the most common struggles I see expressed by my peers in regard to accessing mental health care are financial, transportation, and broadband barriers, the urban-rural divide in mental health care, the lack of mental health professionals and adequate follow-through care, and the stigma around mental health. These issues are incredibly real. My friends have struggled to receive professional mental health services because it's too expensive for their families, too far away, or inaccessible because of unreliable internet access. We need to bring care to where people are, and for teens, that's in schools or at home. In addition, we know that the lack of mental health professionals in the United States prevents teens from receiving the help they need. One of the ways we can approach this issue is by funding a national youth line. We know that peer-to-peer support works and that there is a substantial need for it. What youth need is to be able to call in the new 988 and have the opportunity to be connected with another trained teen. 3, we must invite youth to the table and value their insights as natural partners in this work. I am just one of 165 Youthline volunteers. What does that tell you? Youth aren't afraid to talk about mental health. If anything, adults are. Across the country, young people are mobilizing and advocating for mental health like never before. Beyond Youthline, I've been involved with organizations like Active Minds, through whom I and millions of my peers help to change the narrative for how we talk about, value, and seek care for our mental health. My peers and I believe that we deserve a seat at the table. While there are many ways we can do this, it starts by ensuring that young people can meaningfully contribute to and be involved with legislative work on the local, state, and federal level. If there's anything I want to leave you with today, it's this. Teens are talking, and we need you to listen. At Youthline, we know that the work we do makes a difference in the lives of young people across the country. And we know that because of what we hear from teens after we've connected them to help, after we've talked about self-care, and after we've helped them find a path forward. 6:26 p.m. I feel so much better talking. 8:34 p.m. If it weren't for this conversation, I wouldn't be here today. Thank you.
Trace, thank you for getting us off to such a powerful start. And what I want you to know, you said that young people were mobilizing. Those are very welcome words. And I think you're going to see today the Democrats and Republicans in the United States Senate, the Finance Committee, are going to start mobilizing to move real reform. And make no mistake about it, you and young people are going to have a seat at that table. when we're working on these reforms. So thanks for getting us off to such a strong and powerful start. Dr. Benton, let's see where you are. Dr. Benton, from Children's Hospital of Philadelphia, you have the honor of trying to keep up with Trace. It's a big challenge, and you do wonderful work, as Senator Casey said.
Thank you, Chairman Wyden, Ranking Member Crapo, and members of the committee. Thank you for this opportunity to testify. I wish there were no need for me to appear today, but children and adolescents are experiencing mental distress at higher rates and with more dire consequences than ever before. In the first half of 2021 alone, we reported cases of self-injurious behavior and suicide in children ages 5 to 17 at 45%, higher rates than during the same period in 2019. And for children under 13, the suicide rates for Black children have increased at twice the rate for white children. The pandemic has both highlighted and worsened disparities in pediatric mental health care. There are barriers to access, under recognition, and under treatment of mental health disorders. The burden of illness is worsened for children of color who often have greater exposure to environmental traumas. It is also true that children with mental health challenges are overrepresented in the juvenile justice and child welfare system, where higher rates of mental health disorders are often unrecognized and untreated. You've heard many of these statistics before, but I'd like to share with you how these situations show up in my day-to-day life as a physician. A 5-year-old in the emergency department who disclosed suicidal feelings and plans to run into traffic in reaction to her parents' job loss, financial stresses, and her mother's depression. A 6-year-old boy suspended from first grade for kicking a desk after witnessing a shooting 20 feet away from him while walking home from school, too terrified to disclose the experience for fear that he would be the next victim. A 16-year-old honors student becoming depressed after a romantic breakup, eventually making a serious suicide attempt while waiting 6 weeks for treatment, and then hospitalized for 2 weeks in a medical facility where he waited for inpatient psychiatric care. And then when it was available, financial barriers interfered with a smooth transition. It's situations like these that led the American Academy of Child and Adolescent Psychiatry, the American Academy of Pediatrics, and the Children's Hospitals Association to sound the alarm for kids and to declare a national emergency in children's mental health. But there are things that we know. Children and adolescents recover best when care is targeted to their needs, evidence-based, no more restrictive than it must be for safety and close to home. And while I can speak more directly to the shortage of child and adolescent psychiatrists, there are also severe shortages of other pediatric mental health providers, which all must be addressed. These shortages lead to increased emergency visits for things that are preventable. At my home institution at Children's Hospital of Philadelphia, we have 20 to 30 patients boarding, awaiting acute psychiatric care. And this is true on any given day. We typically operate at full capacity, so occupied beds prevent children with complex medical needs from receiving care. But despite the things I've just shared, I remain optimistic. Effective strategies exist for preventing and treating pediatric mental and behavioral conditions while supporting the natural resilience of children and families. But success will require a response to 2 urgent tasks before us. First, addressing the immediate crisis that we are facing right now. And second, reframing our pediatric mental health system with the goal of preventing disrupted development and facilitating a successful transition to adulthood. Expansion of the workforce will take time, even if we start today. So I'll focus more on immediate options to address the crisis. One of the best things that we can do is to support those on the front lines now by providing them with effective training. This should also extend beyond primary care pediatricians. Caregivers and educators can be empowered through training to better manage the situations they face. And we must act now to pivot mental health services from crisis-driven care to prevention and make sure that needed treatments are available where families are likely to be, such as pediatricians' offices, daycare, after-school programs, and schools. The pandemic has also taught us important lessons. Telehealth has been an important tool for providing care across state lines in underserved areas, rural areas, local and distant communities, and for working families. It's had surprising therapeutic advantages, such as seeing the whole family and seeing them in their natural environment. This tool must continue as adjunct to our current continuum of treatment. And I cannot conclude my remarks without noting that both coverage of the range of services kids need and the appropriate reimbursement for these services are essential. The continuum of services needed for children for mental health are absent at every level. Children need to get the right treatment at the right time at the right place. And finally, I want to end by sharing an experience that reflects my hope for the future. Just last week, I interviewed two fifth graders, Daniel and Caitlin. They asked me, when can normal feelings like depression and anxiety become bad for you? These are questions that all Americans should be asking at this time and able to answer. I want to thank you again for allowing me to provide this testimony. I am confident that you will take this opportunity to secure our nation's future by supporting our children through the crisis. Thank you.
Dr. Benton, thank you very much for helpful testimony. And I noted you talked about access to coverage and reimbursement. We think that is very much intertwined with some of these big insurance companies not following through on parity, which is so essential for mental health patients. So you gave us a lot of very valuable input, and we look forward to working with you. Now we'll go to Ms. Jody Lebarski.
Good morning, Chairman Wyden, Ranking Member Crapo, Senator Hassan, and members of the U.S. Senate Committee on Finance. I want to thank you for the opportunity to testify today as a witness regarding pediatric mental health. I'm both humbled and grateful for this opportunity. I currently serve as the Vice President of Clinical Operations for Youth and Family Services at Seacoast Mental Health Center. We are one of 10 community mental health centers in the state of New Hampshire. I'm also a licensed clinical mental health counselor, still actively seeing pediatric patients, a youth swim coach, and a parent. In March of 2020, life for all of us changed as we once knew it. As adults, we made many quick pivots to respond and adapt to the COVID-19 pandemic. As we made many adaptations in both our personal and professional lives, we had our past experiences to reflect upon. When faced with the new and often unpredictable challenges the pandemic created, we pulled from our toolbox of coping strategies. We knew who we could turn to for the extra support we might have needed as we navigated those challenges. But for most of the youth in our country, they were left feeling paralyzed, stymied, hopeless, and scared. For many youth, this was their first experience with grief, trauma, depression, or anxiety. Life for them had completely changed and their worlds were turned upside down. The uncertainty, social isolation, and stressors related to the pandemic have left many kids unable to cope or understand the breadth and depth of this experience. And for some, there is no trusted adult to support them during this critical developmental period, and their only means of symptom relief is contemplating death. We are learning that teenage girls have begun to demonstrate an increase in the acuity of their symptom presentation. Data from the Centers for Disease Control and Prevention indicates a 51% increase in suicide rates and suicide attempts by teenage girls ages 12 to 17. LGBTQ+ youth continue to have higher rates of suicide than their heterosexual peers. Data from 2020 demonstrated that the percentage of emergency department visits for mental health emergencies rose by 24% for children between the ages of 5 and 11, and 31% for those ages 12 to 17 compared to 2019. Youth mental health has become the secondary pandemic to COVID. As mental health needs rose for pediatric patients, the availability of services continues to become more scarce. Youth are presenting to hospital emergency rooms in a state of psychiatric crisis. Many who are assessed and meet the criteria for psychiatric inpatient level of care will be faced with boarding in an emergency room for days, weeks, and sometimes months before a bed becomes available. Emergency room boarding often creates more distress, decompensation in psychiatric symptoms, and increased traumatic exposure while receiving no mental health care until the inpatient bed becomes available. Staffing shortages in both outpatient and inpatient settings due to an exhausted, depleted, and underpaid mental health workforce has only prolonged access to care for pediatric patients. Without adequate funding and reimbursement structures from both Medicaid and private payers, mental health providers are left with the difficult decision to leave the nonprofit world and enter a for-profit world in order to make a livable wage. During the pandemic, there were 2-3% increases to Medicaid rates. And while that's appreciated, prior to those 2 increases, there had not been meaningful increases in Medicaid rates in over 20 years. Without a realistic reimbursement structure based on the current cost of living, centers are losing staff who can no longer afford to work in mental health settings. Some mental health centers are reporting a 40% rolling 12-month turnover rate in staffing during the pandemic, leaving no workforce available to attend to the critical and fragile needs of pediatric patients. And for the mental health workforce that remains, they are often left supporting higher caseloads than their private practice peers with limited time while attending to significant administrative tasks that private mental health providers are not expected to complete. The community mental health workforce treats some of the most complex cases. The complexity of cases, severity of needs, and demands placed upon this workforce during the pandemic have left many professionals questioning their longevity in the mental health field. A field many mental health professionals entered with an altruistic spirit, now left feeling broken and tired. While we can discuss an ideal service array, evidence-based practices, and ideal care settings, none of this can be provided without a robust, well-trained, adequately compensated, and sustainable mental health workforce from all professional disciplines and degree levels. Simply put, we need to be able to adequately reimburse mental health providers in order to compensate the mental health workforce. Adequate reimbursement will help to sustain a robust mental health workforce to provide high quality, timely, adequate care to our pediatric population. I thank you for your time today.
Thank you very much, Ms. Lubarsky. And you finished so powerfully with the workforce. I just wanted to come back for a moment and say thank you for mentioning at the outset that in those first days of the pandemic, you reached for your mental health toolbox, because that's really what this is all about, is making sure that practitioners, not somebody micromanaging in Washington, D.C., can have an adequate, array of tools. And as you know so well from your outstanding work, too often the toolbox is pretty barren in much of the country, and that's what Dr. Murthy told us last week. So thank you. I know you're going to get some questions in a moment. Dr. Sharon Hoover, next, please.
Thank you. I want to express my thanks to you, Chairman Wyden, for the invitation to speak with the committee today and for your leadership on the issue of mental health in our nation, including the impact on youth. Thank you also to Ranking Member Senator Crapo and to all of the committee members for your vision to improve the mental health and well-being of our young people, and just for the opportunity to be here with you today to talk about these important issues. I'm speaking to you from my perspective as co-director of the National Center for School Mental Health, which is funded by the U.S. Department of Health and Human Services, and as a professor of child and adolescent psychiatry. But I also speak to you through my lens as a parent to 3 teenagers, all of whom had their learning landscape significantly altered during COVID, with almost a year of virtual education. They, along with most children across the globe, had significant disruption to their learning and to their well-being, though I'm fortunate that my kids are now going to school and they're doing well. But we know that many are suffering. Even before the pandemic, youth mental health challenges were rising, with suicide being the second leading cause of death for young people ages 10 to 24. As noted by Surgeon General Murthy during last week's hearing, one of the most central tenets in creating accessible and equitable systems of care is to meet people where they are. And for most young people, this is in schools. I often think back to a story that my dad, who is now 85 years old, told me about his first day of school. He grew up in a small rural town in West Texas called Spur. They didn't have pre-K or kindergarten, so it was first grade. And on that first day, he recalled that his peers and he received toothbrushes from his first grade teacher. It was the first toothbrush that he had ever owned. And I remember asking him, "You didn't have toothbrushes?" To which he replied, "No, my family wouldn't have spent the money on toothbrushes back then." Mind you, my dad went on to a long career in computer science, and he helped create coding to put astronauts on the moon. But he often credits those teachers in his early years who cared about him with setting him on that path. And when I consider that moment when he received his first toothbrush on that first day of school, I think of it really as a classic example of how our schools are a vital place to promote our children's health and well-being. We simply can't rely on our healthcare system alone to support the mental health and well-being of our young people. We know on average, as Senator Wyden noted in the beginning, that people do not get into care for over a decade after the initial onset of symptoms, and half of mental illnesses begin in the school age years. Our traditional approach to mental health care has not leveraged the natural venues where our young people access support. It's really akin to waiting for toothaches and cavities and abscesses until a child gets proper dental care. Instead, we should do the equivalent of passing out toothbrushes and providing preventive and early dental care by offering every child in every school the social, emotional, behavioral, and mental health supports that they need to be successful. Increasingly, schools have comprehensive school mental health systems, which reflect partnerships between education and behavioral health sectors to support a full continuum of mental health and substance use services and supports, from promotion to treatment. And when treatment is delivered in a school setting, youth are far more likely to be identified early and to initiate and complete care. Schools that have these systems in place recognize that poor mental health leads to poor learning, and positive mental health promotes academic and life success. There are many policy and funding opportunities, including strengthening school Medicaid programs, that can help advance a continuum of mental health supports and services in schools. And Congress has the opportunity to support investment and technical assistance to assure that young people can get the mental health support that they need. In my written testimony, I do provide detail on several steps that federal and state leaders can take to advance comprehensive school mental health systems. And we have witnessed many states adopt new policies to advance school mental health. Tomorrow, the Hopeful Futures campaign, a coalition of national organizations committed to ensuring that every student has access to effective and supportive school mental health care, is releasing the first ever America's School Mental Health Report Card and Action Center, with individual report cards for all 50 states and DC. And these school mental health report cards highlight accomplishments and provide important action steps to help address the children's mental health crisis in every state. They can serve as a great starting point for policymakers who want to strengthen school mental health supports and policies in their communities. And you can find the report cards at hopefulfutures.us starting tomorrow morning. Today, Americans across the country are united in our concern about the mental health of our young people and its impact throughout lives. I want to express my gratitude to you all for opening up this important discussion on youth mental health, for recognizing schools as an essential place to strengthen our children's well-being, and for committing to investing now to create hopeful futures for our nation's youth.
Thank you very much, Dr. Hoover, and we're going to get you into this discussion in just a minute. Trace, you really make all of us in Oregon so proud, and you said it so well. And I want to get into an area that I really hadn't heard about from you, and that is how serious this problem is of young people getting lost in the system, where they just don't get connected. And the figure you used is 80% of referrals from schools for mental health support just go nowhere, just get lost. How does this make students and young people feel when they just get lost in all of this red tape and bureaucracy?
That's a great question, Senator Wyden. And I want to clarify that that statistic was for my school. So I don't actually know the national figure, but I imagine, right, there's similar trends across the country.
That was for your school, right, Trace?
Yes.
Good. Please, go ahead.
But I think, right, when we talk about access to care, right, there has to be a conversation about what happens next, right? What happens next? Who is going to provide the follow-through care? And I think for a lot of teens who get to this point and initially have that first conversation, not being able to get those accesses afterwards is incredibly isolating and incredibly defeating. And I think it really highlights some of the failures of our mental health care system and things that need to be addressed, because teens who need help should receive help, and that help should be meaningful and sustainable for as long as they may need it.
Okay. Sit tight, Trace. Dr. Hoover, that 80% figure is really show-stopping. And my sense is, whether it's 80 or 60 or something, we're just losing a lot of young people at a really crucial time. What ought to be done about that?
Totally agree. And I would agree with Trace that it's probably not just in his school. We're seeing these figures across the nation. So the bottom line is that getting care to kids in some of our traditional outpatient settings really is a challenge. So as you heard earlier, one of the first lines of action really is to bring services to where young people are in their schools. We know that every state and many districts within each state have examples of really effective school-based mental health care, right? So this includes expanding our school employed workforce, including our school psychologists, school social workers, and counselors, but also helping facilitate partnerships with community behavioral health provider organizations to bring their services into schools. School-based health centers are also an ideal model of providing this type of on-site care. So increasing support for school-based health centers is one avenue. We mentioned telehealth already. We know the expansion of telehealth offers incredible opportunity to expand reach of specialists, not just into rural settings, although that's critical, but also into our urban settings. We've been providing telehealth from our hospitals into Baltimore City schools for a number of years now. We heard from Ms. Zaborski on reasonable reimbursement. That is a critical way of getting services to schools and and to outpatient care, and having providers there to receive students when they are referred. So those are some of the avenues.
Well, thank you both. And Trace, if ever there was an area, as you said, for the committee to work with young people, it's mobilizing, in your words, to make sure that we don't see as many of these referrals get lost in the system. It's just too important because those are young people who are getting lost. I want to ask you one other question, Trace, and that is, you and I talked about barriers to care, and clearly stigma associated with mental health challenges is a big part of this. I saw this with my brother, who struggled with schizophrenia for years, as I went off and played basketball and all kinds of things like that. And my concern is I keep hearing from people in the schools and students like yourself that the stigma has clearly gotten worse as a result of the pandemic, causing more young people to be isolated from each other, that there wasn't enough peer-to-peer contact and like. Can you give us your thoughts on that?
Of course, yeah. I mean, I think we definitely saw how the pandemic increased rates of loneliness, isolation, and other high acuity mental health struggles. But I think really the most important takeaway from the pandemic in our response to the mental health care crisis is the fact that COVID-19 exacerbated disparities that were already there, right? We know that access to care was limited before COVID-19, and the pandemic only amplified those barriers. So if a teen's only way of receiving mental health support was with a school counselor, that relationship was no longer there, and they could no longer have that conversation about mental health, right? And that in and of itself is destigmatizing the stigma around mental health. And I just want to bring up, right, like if a teen feels like the only way they can express their emotions is through the barrel of a gun, what have we become as a society in our perception of mental health for young people? And we really need to talk about mental health. And I think that first starts with having this conversation and recognizing how COVID exacerbated already existing disparities.
Trace, we had high expectations for you this morning, and you went way over the bar. So thank you so much, and you're going to have a seat at the table as we go forward on these big issues, and thank you. Senator Crapo is next.
Thank you very much, Senator Wyden, and I agree, Trace, with Senator Wyden's comments. I'm going to let you off the hot seat for a minute, though, and go back to Dr. Hoover and then to some of our other witnesses. Dr. Hoover, for Idaho and other states with large rural communities, the mental health care delivery system looks substantially different from other urban or suburban populations. Even though the need for mental health services is similar between rural and urban areas, it's harder for children in rural areas to access those same mental health services. In your work with the states, can you elaborate on some of the specific risks and challenges that younger Americans living in rural areas might confront with regard to mental health? And I ask this question in the context of you've indicated that our schools, many of them have good programs in place and that they are working well, need to be strengthened and enhanced and given more tools. But focus that a little bit on rural areas. How are we doing there? And what role do schools play in providing mental health services to our youth?
Thank you, Senator Crapo, for the question. And frankly, school mental health is perhaps even more relevant and important in our more rural communities just because of the workforce shortage and also some of the stigma issues that Trace just spoke to. We know that in rural communities, our young people and families often have a harder time accessing services, as you mentioned. And there often is more of a stigma associated with seeking out mental health supports. We hear often, I was just working with some rural counties in Maryland, and we often hear everybody knows each other, right? So seeking mental health supports can be even more risky from a student perspective or even from a family perspective. That being said, we know that schools can be a place where mental health can be destigmatized. So it is one step, I would say, that's critical in rural communities and in all communities is to really make mental health part of the education that our young people experience. So we can establish mental health as part of the K through 12 curricula. A number of states are doing that. I know New York, Florida, Virginia have led the way to infuse mental health as part of what young people learn about. They learn about how to achieve positive mental health, how to recognize if there are some problems, and how to seek support when they actually need support for themselves or for a family member or a peer. So part of it, again, is just reducing stigma, and that's particularly critical in our rural settings. I would say in terms of the workforce, we know we have to get workforce into our rural communities. And some of that will require kind of reaching down into our high school and, you know, certainly our undergraduate training environments. I've worked with some groups in Nebraska who've done an excellent job of really fostering the high school interest in mental health specialties as they come into undergraduate and then graduate training, but also really working with other providers in schools, including our school nurses and other health providers, and even our frontline educators to do some task shifting, right? To adopt some of the skills that they can equip young people with. We don't have to, we really simply can't rely exclusively on our specialty mental health providers, especially when we don't have enough. So those are some of the solutions, and I look forward to working with you on that.
Well, thank you very much. And let me move next to Ms. Lubarsky. I'm not going to have time to get to all the witnesses. I apologize, but we have lots of questions and we'll give you some even after the hearing. Ms. Lubarsky, your experiences can provide a deeper understanding of the range of services provided across the continuum of mental health care. One of the most common concepts discussed in the stakeholder responses we've received is the need for increased coordination and case management to lead to better outcomes. In your role as a community mental health leader, can you explain exactly what targeted case management means in practice when you're caring for the kids and their families?
Yes, thank you, Senator Crapo, for your question. So targeted case management, I really view as a fundamental important service for every youth who's receiving clinical services at a mental health center. When we think about Maslow's hierarchy of needs and that ability to meet your most basic needs in life, that is why we utilize case management with our pediatric patients and their families. If you can't feel food secure, housing stable, be able to access your education in a meaningful way, and really be able to be socially connected to your community in a manner so when you're done with your mental health care, you're moving to your supports in your community, then you're not going to be able to reach that final goal, which may be your therapeutic goal when you're coming in for mental health care. So as providers here at the center, for every youth who's eligible for mental health services, they have the ability to receive targeted case management as well. So we're doing that very nice balance between providing the clinical mental health care while also looking at their needs outside of mental health to make sure we're braiding those worlds together.
Well, thank you. And I'll submit my questions to, for the record, to the other witnesses I didn't get to. Thank you to all of you for your testimony today.
Thank you, Senator Crapo. And as we said at the outset, we're going to make this a bipartisan effort. This is one of the most important undertakings the Finance Committee has been part of, and we thank you for your leadership. And also, focused on bipartisanship, Senator Stabenow, who for years has worked relentlessly to improve behavioral health with our colleague, Senator Blunt of Missouri, is with us. Senator Stabenow, your questions.
Well, thank you, Mr. Chairman. I just want to say thank you to you and thank you to Senator Crapo. This is so important. Spending not one hearing, but multiple hearings on mental health is absolutely critical and has not been done since I have been in the Senate. And I'm very grateful for all of your leadership. And yes, this is an area of bipartisanship where we've begun a process of changing to address healthcare above the neck the same way we address healthcare below the neck and the funding and so on. We have models that work now. We just got to move forward and get it done. And there's a lot more to do. And I want to also just give a shout out to Trace. Thank you so much. Thank you for coming forward and sharing your experience and for now being a part of really making a difference in young people's lives. And part of overcoming the stigma is all of us just telling our own story, the story of someone in our own family, so that we're treating anxiety or mental illness the same way we would if somebody was a diabetic or had a broken leg or broken arm. That is just part of healthcare. And I hope we're going to work together and we're all going to get there. So let me, and by the way, I also wanted to say, Trace, in your written testimony, I appreciate your mentioning both our school-based health clinics that I think are the model for us in the school setting and our certified community behavioral health clinics that really are the model for quality comprehensive care in the community now that's fully funded, where professionals are fully funded so that we can move forward. So, Dr. Benson, I wanted to ask you particularly around that point because I appreciate all of our witnesses and their wonderful testimony. But our community behavioral health clinics that we now have demonstrated in 10 states fully funding what can happen if we are funding behavioral health like our FQHCs, our community health centers with high standards, full funding as healthcare, where we're seeing now the difference that can make. And we're working hard to have this be the structure across the country, really, which I believe can really transform the services we're talking about. But the CCBHCs, as we call them, really make help available where children are, and we nearly have about 25% so far of the community services being given to children, and there's a lot more that we can do. So I wonder if you might speak a little bit more. I know you discussed this in your testimony, but highlight the importance of these comprehensive community clinics, particularly on underserved communities.
Thank you so much, Senator Stabenow, for that question. The community behavioral health clinics are key components of the mental health continuum, and a significant component of the problems we face this year related to those services being overwhelmed by the number of patients and limited numbers of providers. It's vitally important to address equity for all children, to have care in their communities where they are every day, that's accessible to their families, that's culturally competent, and integrates principles of cultural humility. And in academic centers like the children's hospitals, we partner very strongly with the community centers to expand access. And so we should be able to provide and fill in the gaps where they exist in those clinics. So for example, because the reimbursement isn't always what it should be, they tend to run with a lower number of high cost providers. And it's our responsibilities in centers where there are more resources to be able to provide that support to the communities. But without a strong partnership, we'll never be able to successfully address the concerns of young people in our country.
Absolutely. I totally agree. And we can do this. We have done this on physical health. And so we absolutely can do this. I know my time is running out. Time is too short. I have many questions I will submit. I did want to also just indicate that I'm excited that to be leading the committee's working group on workforce issues, which each of you have raised and so critically important. And I'm working with Senator Daines, my colleague, on this, and we'll be reaching out to each of you to ask for your further input. So thank you, Mr. Chairman.
Thank you, Senator Stabenow. I was about to mention the good work that we know you're already beginning with Senator Daines, so our guests have an understanding of how we're going to work. We have got a Democrat and a Republican serving on each of the key areas that we have to tackle. And because Senator Stabenow's expertise in this area and her advocacy is so important, I think we're especially lucky to have her handling the workforce issue, which I think we've all heard people mention repeatedly. So Senator Stabenow, Senator Daines are going to be playing a key role, and we thank her for all her leadership. Senator Grassley is next, and we welcome him.
Thank you, Mr. Chairman. I'm going to lead into a question for Dr. Benton. In September, the DEA issued its first public safety alert since 2015. It warned of a significant nationwide surge in counterfeit pills that are mass-produced by criminals in labs, deceptively marketed as legitimate prescription drugs. These counterfeit pills are killing unsuspected Americans, particularly young people, and it's at an unprecedented rate. Many youth are getting illicit pills knowingly or unknowingly through Snapchat or TikTok. This use of illicit drugs is driven by mental health challenges, anxiety, suicide thoughts, and resulting in accidental overdose deaths. So do you believe that kids dying of suicide or accidental drug overdose is driven by mental health challenges?
So thank you for that question, Senator Grassley. And it is a complicated one. And so, definitely there are increases in rates of mental health conditions that contribute to suicide. But mental health conditions are not the only factors that contribute to completed suicide, which is one of the reasons it's been so difficult to prevent. So environmental factors, other things that you just identified, exposure on the internet to all kinds of unregulated advertisements for young people, all contribute to those challenges. I also want to call out something else that you've highlighted with your question, which is the focus on medications and the focus on pill treatments for young people with mental health conditions discounts the fact that most young people actually need psychosocial interventions. And so that there are multiple environmental factors, psychosocial factors, and other treatment factors that we need to consider when thinking about treatment, not just emphasizing pharmacologic treatments that are available, which I think would diminish some of the focus on young people obtaining medications.
I'm going to go on to another subject, Dr. Benton. In your written testimony, you mentioned the importance of patient-centered medical homes for kids to improve access. 2019, we passed the bipartisan ACE Kids Act, establishing pediatric home health for kids with complex medical conditions. Last fall, the Centers for Medicare Services issued guidance for ACE kids and is working with Medicaid programs in the same way. For you, Dr. Benton, is access to out-of-state provider a challenge for kids with complex medical needs? And let me follow it up with what might be my last question. For kids with these needs, what does coordinated mental and physical health care look like, and describe medical home?
So thank you, Dr. Grassley, for your leadership in this area. So the patient-centered medical home has provided significant support for young people with complex medical conditions. We still have work to do in the area of integrating the medical and mental health benefits and treatments. And so, in the patient-centered medical home, we do better at providing mental health support for young people, but we still face challenges around parity for mental health and medical services. So within our own institutions, when young people come to us locally or from out of state, frequently the medical benefit is accepted and easily accessible. But when those same youngsters need mental health treatment, they frequently find themselves in a situation where they're being billed for a service that's out of network, or they're not paid at all. And it poses significant challenges for families who deserve the care that their child needs, but the parity issues remain barriers. We've made significant progress, and I look forward to your continued work in this area in leading us through these complex comorbid conditions. We've made progress, but we still have more work to do.
For Mr. Terrell, you'll have to give a short answer to this because my time's out, but what efforts should be taken to address unique rural mental health needs?
Like I said, access to care is super important. And I really appreciate this question just because I think youth have so much stewardship and insight about this issue. So I think if we can really bring, personally, I live in a rural community, and what I think would be really helpful is if we bring care to where people are. And that means funding school-based health centers, CCBHCs, and other community-based mental health supports that really help teens just get the support that they need. It's easier to be on a school campus and get medical services than it is to be at home, have to coordinate transportation, and get there, which is a barrier that so many teens in rural communities face.
Thank you. Thank you, Mr. Chairman. I'll commit questions for writing.
Very good. Senator Cantwell's next, our Northwest partner. Senator Cantwell, are you online? Let's give this just a quick moment because I think she is. Senator Thune. It would be after Senator Cantwell. Senator Menendez. Senator Portman. Senator Carper. And for our guests, you should know that this is a particularly hectic day in the Senate, so members are going to be coming in and out. Senator Carper. Senator Cassidy is here. Senator Cassidy, a very valued member with his expertise on healthcare as a physician. Senator Cassidy.
Yeah, thank you. Thank you very much for that. By the way, I thought I had 15 or 20 more minutes to listen, and everybody else is out. So anyway, thanks for going there. Dr. Hoover, I used to work with school-based clinics to do hepatitis B immunization, very aware of how well they can function bringing care. Now, first, I think we have to acknowledge if the child is not in school, it's difficult for the child to be evaluated. But that said, but now the kids are back in school, so there's some progress there. But let me ask, and you may have covered this, I was in another committee hearing. My understanding is that the schools and the school systems would benefit would CMS give some updated guidance as to the possibility of providing these services in that venue. Any comments on that, Dr. Hoover?
That's exactly right, Senator Cassidy. I appreciate the question. And you are correct that it is easier to get school-based care to young people when they are actually in schools. And one of the things that we are hoping Congress can support is really urging CMS to modernize the existing school guidance for Medicaid in schools. This guidance has not been updated since 2003. And it's critical for states and education and state Medicaid agencies to work together to actually be able to support and resource mental health providers.
Now, let me ask you, I have limited time, put a point on it. What is the problem with the current guidance or lack thereof that limits the ability to expand mental health services through the school-based clinic?
Yep. So just quickly, a lot of states don't want to move forward with implementing the current Medicaid supported mental health services in schools. They're worried, they're hesitant that expanding their programs may put them at audit risk. The guidance really is not updated to reflect improvements in telehealth. It's not updated to reflect the free care policy reversal in 2014. So there are a number of updates to Medicaid that would need to be reflected in this guidance for states to feel comfortable moving forward.
And specifically, you mentioned telemental health. I'm really struck. If you look at adolescent psychiatrists in my state, they're in the cities. They are not in the rural area. So one, the infrastructure bill will expand internet services throughout the state. That'll be huge. But secondly, you got to get the adolescent psych who's in Shreveport to be able to communicate to the child who might be in Wynn Parish. You don't know the geography of my state, but suffice that's urban to rural. What impediments right now does the rule give as regards the utilization of that telemental health?
Yeah. So as you know, during COVID, we saw a huge expansion of telehealth, and we know that providers and families need guidance and technical support to actually use the telehealth equipment. But more important than that, we need to see the continued expansion of reimbursement and policies that support teleproviders to be able to not only provide services within their communities, but even across state lines as necessary to address some of the workforce shortages.
Now, if you gave advice to this committee, because we have jurisdiction over Medicare, Medicaid, CMS, one, you just to urge CMS to update these. And again, is there any single point? You're talking to Wyden and Crapo right now. They're the straws that stir the drink of Medicaid, Medicare, and CMS. So if you had to kind of just sit down and pound your hand on the table, what would you say, our chair and ranking member? We got to get this done before we move on.
Absolutely. I would say that Congress should encourage all states to cover all medically necessary mental health services, including prevention services for all Medicaid enrolled students, and simultaneously ensure that school Medicaid programs have updated guidance, best practice, and technical assistance that they need.
Ms. Terrell, can you just put the dot on the I as regards the importance of school-based clinics as regards provision of mental health?
Of course, yeah. Like I said, this is a great question because I think it's so relevant. And when the teens are able to get care where they are, that just encourages help-seeking behaviors. It promotes developing systems of self-care, and it really promotes general health and well-being outcomes. I think the fact that teens are sometimes able to just walk over to a medical clinic and get the help that they need is so essential, especially if they're not able to at home. They don't have reliable internet access. So when we concentrate our efforts on schools, it's really important to make sure that we build these natural partnerships and kind of leverage the power within those.
I will just add to that from my experience working with school-based clinics. Sometimes there's issues which should not be, for example, abuse by a parent, which can be discussed in the safe setting of a school-based clinic with a licensed healthcare provider. And it also, frankly, helps the business model of the school-based clinic. In some states, they have a very difficult time keeping their doors open. So if they can provide a needed service, it actually benefits. With that, I yield back, Mr. Chair.
I thank you, Senator Cassidy, and for our guests, Senator Cassidy and Senator Carper are going to be leading the task force on young people, so they're going to be invaluable on the issues we're dealing with. We now have an order of Senator Cantwell, Senator Thune, and Senator Menendez, and members have been coming in and out. Senator Cantwell is next in the order.
Thank you, Mr. Chairman. And continuing on that same theme of young people, Ms. Lebarsky, the Surgeon General's December advisory on mental health stated that 1 in 3 high school students and half of the female students reported persistent feelings of sadness and hopelessness during the COVID pandemic. So we already know what our challenges are. The Washington Hospital Association reported that during the past 2 years, major depression disorders are leading youth inpatient diagnosis in my state. So when it comes to seeking treatment, not everybody gets a fair shot at that. The numbers on individuals with lower income is that they're at nearly 20% higher than the rates for those people with higher income. So affordability is a factor. I know my colleague, Senator Stabenow, had a chance to ask questions earlier, but I'm very supportive of her certified community behavioral health clinics. These have been great programs. There are 5 community clinics in my state that serve low-income populations, and this grant over the past 2 years has been used to enhance the care of those experiencing mental illness. So we really are building capacity. Clinics like Comprehensive Healthcare in Yakima were used for innovative purposes, creating a program to offer mental health first aid training, critical incident stress debriefings, and helping to receive support. So do you think that these programs, such as the Certified Community Behavioral Clinics and their grants, have been helpful in reducing the barriers for treatment of youth and families, particularly in some of our less accessible areas in more rural parts of the United States? And should Congress consider expanding these programs to address disparity in access? And what would you prioritize within that system?
Senator, thank you very much for your question. I am so pleased that you mentioned mental health first aid. As a youth mental health first aid instructor, I think it's also a vital component of our prevention of youth mental health. In regards to the CCBHCs and other healthcare facilities, I think they're one of many ways that we reduce the barriers to accessing mental health care for our pediatric population. There really is no one size fits all for the right delivery model. And so where some youth and their families are comfortable coming into an outpatient clinic, because of the stigma that's often attached with mental health services, I think having the ability to access your mental health care at a community health center, at a pediatric office, at your school setting, or through a telehealth device is crucial to make sure that we have mental health care accessible to everybody. In our community, it may be hard for some of our families who lack adequate transportation to get to our offices. Yet one of our federally funded healthcare facilities is on a bus line. And so we've worked in partnership with that healthcare facility to have mental health staff there. So if that's the only means by using public transportation to get to the appointment, families can still access their healthcare. So I think it's critical.
And what about this issue that you bring up of integrated healthcare? So, treating mental health and other physical health in the same location, because most times people come with both issues and or things that exacerbate one or the other. And like you said, so there's less stigmatization and the treating of the whole person.
Absolutely. It's critical because I really do think physical health and mental health braid together. And when our mental health is not doing well, we'll see a decompensation in our physical health symptoms, whether that's poor sleep, poor diet, isolating from others, not engaging in physical activities that can promote good mental wellness. And so you really do have to bring the physical and the mental health worlds together for the whole self.
Well, thank you. Is there anything you would prioritize in the improvements of that program if we had more dollars for the certified program?
I think, as I spoke to in my verbal statement, it's really around those reimbursement rates and making sure that we're reimbursing centers, individuals, organizations in a meaningful way to sustain the workforce in order to deliver the crucial care.
Okay, great. Thank you, Mr. Chairman.
Thank you.
Thank you, Senator Cantwell. And the Northwest is going to be very united in this effort and look forward to working with you. I believe Senator Menendez will be next. Senator Menendez, are you out there online? We may have lost Senator Menendez. Senator Menendez? Senator Portman is next then.
Thank you, Mr. Chairman. Appreciate it. And I appreciate the testimony and the fact that you all are in the trenches every day doing great work with our young people. Dr. Hoover, you talked about telehealth, and I just want to be sure that we're also focused on the broader behavioral health and specifically substance abuse. It seems to me that telehealth is one of the few silver linings in an otherwise dark cloud of COVID. And with regard to substance abuse treatment, that there has been some real improvements. Would you agree with that?
I would agree with that. I mean, certainly the opioid crisis has brought attention, and that has been exacerbated during COVID. So the funding provided by the federal government to states and communities to support the opioid crisis has been tremendous. And certainly there's been an improvement in care. Telemental health has improved that as well.
This is why we've got to continue the reimbursement under Medicare, Medicaid particularly for substance abuse at a time when we had 100,000 drug overdose deaths in the period from April this year to April last year. So during 1 year, a record level. That was a 28.5% increase in overdose deaths. Really heartbreaking because we had made great progress in 2018, 2019. Now we're unfortunately seeing more and more people dying of overdose deaths. The reporting we have about young people, because that's the topic today, shows that we have seen anywhere from an increase of 3 times higher number of overdose deaths to 13 times higher in 2021 compared to the numbers we had from 2019. And by the way, dramatic increases among Black youth in terms of overdoses. It's particularly concerning. Ohio State has done a report recently, looked at it from a different perspective. They said how many years have been lost. And so their analysis is that beyond the numbers we already know, the loss of years lived for more than 21,000 young people who they tested from overdoses show that adolescents and teenagers 10 to 19 lost cumulatively 200,000 years of life. And when they expand the study to include 10 to 24-year-olds, it grew to more than 1 million years lost. So it's a shocking way to look at it, but think of all that lost potential and all that God-given potential being ruined. So this is a huge reason that we need to figure out as a Congress how to get back on this issue. And deadly fentanyl is killing, we think, about 2/3 of these kids. So this is synthetic opioids streaming across the border. We've done a lot more in terms of the prevention side and the treatment and recovery side, but obviously not enough. And what we see in Ohio is that this deadly fentanyl is often masked as other substances. So it looks like a pain medication or an anxiety medication or ADHD medication. And we've had parents approach me in Ohio to talk to me, about this issue because they believe that their son or daughter died of an unintentional overdose by being deceived about what was in a pill. So, Dr. Hoover, talk to us a little about that. Anybody else jump in? What do you think the reasons are for this big jump in overdose deaths, and how much of it do you think is attributable to these cartels putting fentanyl into other medications?
So I'll jump in quickly and defer to Dr. Benton on the kind of impact of drugs and the medical side of this. But certainly in terms of the comorbid mental health issues, we know that the substance use issues we're seeing increase in young people are likely very related to their increase in depression, anxiety, and post-traumatic stress. Not only are we seeing increases in that pre-pandemic, but we're seeing real exponential growth in that in the context of COVID. So we know when that happens, we see increases in substance use. And so it's not surprising when you give those really tragic numbers. I'll defer my time over to Dr. Benton with respect to
You're talking about self-medication because of other behavioral health or mental health challenges.
That's a piece of it, absolutely, that self-medication to address anxiety, depression, trauma, and just to really cope with some of the isolation and loneliness that our children have experienced over the last couple of years.
Dr. Benton, can you talk a little about the synthetic opioid issue, the fentanyl getting into other medications?
Yeah, so what I can say is that we are seeing increases in utilization across the country. And unfortunately, I have to say that in many mental health programs, there's not the robust substance use and addiction treatments that we'd like to see. And a major focus of expansion of resources and treatment for young people needs to focus on increasing the integration of substance use and mental health treatment services. We know that for young people with any mental health condition, the comorbid use of substances only makes the outcomes worse. And the substance use is associated with worse outcomes, including suicide and other impulsive behaviors that land young people in bad situations. And so that has to be a focus. Right now, they run almost as two separate systems in some ways. And that really needs to be a focus of our efforts going forward if we're going to address the substance-related morbidities that we're seeing right now.
Okay, I think my time has expired, but Trace, I'd love to hear from you on this. If you have a minute, Mr. Chairman, if Trace has any thoughts.
Yeah, I would love to. Thank you, Senator. I think, right, when we talk about all these statistics, it's really alarming, but I also think that there is a beacon of hope. Since Youth Line's inception, we've experienced an annual increase in contact volume of about 15% annually, with an additional increase of 3 to 5% since the COVID-19 pandemic. And obviously, while that proves that there is a need for mental health care, there's also so many teens reaching out for help. And I think that is really inspiring. And I think it shows the resilience of teens in regard to mental health challenges and substance use challenges. And so I think if we can really ensure that the people reaching out for help are able to receive help, we will get really far on this issue.
Thank you.
Thank you, Trace. Next is Senator Menendez.
Oh, thank you, Mr. Chairman. Across the Congress, we all talk about the provider shortages the nation is facing, especially mental health providers that are available for Black and Latino communities. and the pandemic has taken a disproportionate toll on minority communities, and the provider shortage has only grown more dire. More dedicated support for a larger and more diverse pediatric workforce is critical, I believe, to address children's mental health needs now and into the future. So, Dr. Benton, what are 3 things this committee can do to address the recruitment, training, retention, and professional development of a diverse clinical and non-clinical pediatric mental health workforce?
Well, thank you for that question, Senator. And it's one of the issues that I struggle with every day as a training director and as a physician. Some of the things that we could do now is developing pipelines at a much younger age. So in my testimony, I mentioned the 5th graders interviewing me. They were interviewing me about why did I become a child psychiatrist? And I was really pleased that they're asking these kind of questions in 5th grade. So starting a pipeline where we're present and we're reaching out to communities of color is really important. Education and destigmatizing mental health conditions in the Black community and the Latino community by partnering with trusted community organizations. Loan repayment is an incredible issue. Many of my physicians say, I can't afford to work for you because I have loans to repay and you don't pay enough. And so loan repayment for all the mental health professionals, I think, is important. And incentives for people to choose mental health. That could be part of loan repayment or some other payment measure would be really helpful. And then reaching into the communities where minority populations are would be extremely important. So we tend to recruit from communities that are affiliated with academic centers, and we don't reach into the communities where patients are actually receiving services. Those are some of the things that we could do now to support diversification of our workforce.
Well, I appreciate those insights, and we may reach out to you to build upon them as we explore the initiatives here. In part of the reason I raise this, I look at the first half of 2021 alone. Children's hospitals reported cases of self-injury and suicide in ages 5 to 17 at a 45% higher rate than during the same time frame in 2019. And for children under 13, the suicide rate is twice that for Black children than for white children. So what can we do to reduce the likelihood of suicide in children and adolescents, particularly minority youth? And how do we better target our resources?
Thank you, Senator Menendez. This is one of my areas of passion. So among minoritized youth, across ethnic groups, the rates of suicide attempts are higher than they are among non-minority groups. And one of the challenges has been identification among minoritized youth and access to services that are culturally competent and or demonstration of cultural humility. The data demonstrates pretty strongly that culturally concordant therapists and patients have better retention in treatment and better outcomes in treatment over time. And certainly, it will never be the case that we will have one-to-one matching for patients by ethnic group, nor am I sure that is the goal. But the goal is for groups where there's not concordance between the patient and the therapist, that there be cultural humility, that we train individuals to learn to inquire and understand the cultural experiences of others when we're engaged in treatment. And so the training opportunity is there, but it's essential because we are seeing for youth across each ethnic group increasing rates of suicide while they are declining for non-minoritized populations. So it's vitally important.
And finally, about roughly 17,000 3- and 4-year-olds are expelled from their preschools each year. And despite Black children making up only about 18% of the school population, they make up 40% of all expelled children. And even more troubling is that within the high rate of expulsion for Black toddlers is how often Black boys are expelled. So how can we better support training for pre-K teachers and child care providers in basic behavioral health techniques to combat bias and give these important social emotional regulation tools to children from their earliest ages? And I'm happy to entertain anybody who can answer that.
Well, thank you. Thank you, Dr. Menendez. And I would hope that Dr. Hoover would respond as well. Prevention and education is key. Addressing bias among school personnel is essential to address this, and providing more resources and supports in centers where children appear every day, in daycare and in primary care, with some preventive education around what's normal and abnormal development. I'm sorry, Dr. Hoover. I wanted to give you an opportunity to comment.
Not at all. I know the time is short. I'll just quickly add that investment in early childhood mental health consultation programs across states is critical. And as you alluded to, culturally responsive teaching practices, there's a lot of evidence to suggest that those can help in reducing discipline referrals and expulsion.
Thank you all.
Thank you, Senator Menendez. Senator Cardin is next.
Thank you, Mr. Chairman, and let me thank all of our witnesses. I think this panel has been extremely helpful. This is an area, as you can tell by the questions, you don't know who the Democrats or the Republicans on the committee, that we have a mutual desire to try to get this right. And we recognize we have a real challenge in mental health in this country, but particularly with our youth, with the experiences of COVID-19, we know that we have a greater challenge than ever before. So I want to talk about the school setting for one moment, what we can do. I am responsible as one of the co-chairs of the groups that Senator Wyden has been talking about to deal with telehealth. And I'm curious, you've all talked about the importance of expanding telehealth, but what are the challenges within the school setting of expanding telehealth services? Where do we need to try to put our attention, either change of policy or resources, in order to expand the productive use of telehealth in the school setting? Either Dr. Hoover or whoever would like to respond to that, perhaps start with Dr. Hoover.
Sure, I'm happy to jump in. Thank you, Senator Cardin, for your leadership in this issue of mental health across the nation, and specifically in the area of parity and telemental health. We know telemental health has actually been in the schools for years. Our child psychiatrists were delivering telemental health across schools in Maryland and in Baltimore City back when I was delivering services in the early 2000s. We know that there are continued infrastructure improvements that are necessary to improve telemental health services in schools, and that would include enhanced broadband systems, up-to-date telehealth delivery equipment, internet connectivity services, especially to some of our rural communities. We know that policy expansion is important, including reimbursement parity for telemental health, and expanded access to Medicaid and children's health insurance telehealth programs. So there's a number of areas that we've seen improvements in during COVID that we need to continue and to expand. And that applies to schools as well.
If I could get either your view or Dr. Benton's view, we made a lot of resources available to our school systems in response to COVID. Have they been used to expand the connectivity that you're talking about for mental health services?
Some have, and again, happy to defer to Dr. Benton here as well, but some have. One of the things we know, though, is that some of the COVID relief funding, for example, is creating kind of one and done or some hiring, short-term hiring fixes. But we know that it's critical to make some of these Medicaid policy adjustments so that we can allow for sustainable funding for telehealth and other mental health services. Dr. Benton?
Yes, I would concur with Dr. Hoover. I think many of the systems have used the resources well, but many of them were understaffed before the pandemic and did not have access to adequate resources. They've reached out for telehealth, but there are a variety of factors that impact their ability to optimize its use. Some of them are the privacy standards. So communications between mental health providers and schools through HIPAA and FERPA are issues that really need to be addressed in communicating about mental health concerns. Some schools may have one or two school counselors, but not necessarily access to a provider team of psychiatrists that can partner with the schools, as Dr. Hoover described, to provide that additional level of care that's not necessarily available in the schools. And then in addition to that, we do need to think about our care models very differently. So for example, there are services that are cheaper to set up that are available right now, such as school-based crisis services. So when a school is under-resourced and there's a crisis, it's very possible to send someone to that school to see that youngster on site with the family, or urgent cares that are on site at schools. So there's some other things that we could do to support our schools. So I thank you for your leadership in supporting the schools through the pandemic. We should retain those things, and there are other things that we could do to expand access.
So Dr. Benton, you talked about the need to have improved screening in regards to mental health for our students. Can telehealth be helpful in dealing with screening, recognizing that you need personnel in the school itself, but can that be better utilized than we're using today for screening?
Yes, yes, Senator. That's an excellent recommendation. And yes, it would be very helpful. One of the challenges for schools is they screen and then they can't respond. And so having telehealth allows them to screen youngsters for problems or challenges before they become major problems. And telehealth can be used to address some of the more acute things on site. Currently, screening is not viewed enthusiastically because if you find something, you can't do anything about it. The utilization of telehealth to connect with a crisis provider would allow the school to be able to respond in a safe and effective way. And thank you for
Thank
that
you, Mr.
question.
Chairman. Appreciate the response.
Thank you, Senator Carper, and we appreciate your leadership on these issues as well. Next, I believe, Senator Langford, are you out there? Senator Brown, Senator Barrasso, and Senator Bennett are both here. Senator Barrasso and then Senator Bennett.
Well, thanks, Mr. Chairman. And first, I want to congratulate and compliment you on your opening statement. I thought you really hit the point on the head in terms of how long this is often brewing before we know of the problems. I mean, I'm an orthopedic surgeon, worked with many people as president of the Wyoming State Medical Society. I think you're absolutely right in the comments that you made. As being from Wyoming, rural health is a big issue for us, and Senator Crapo started by talking about that. And then telehealth is something we've used from a mental health standpoint long before the pandemic. I think the pandemic has brought mental health as well as other kinds of healthcare to the fore in terms of the ability to try to use telehealth much more productively. I think we're hopefully fast forwarded with the acceptance of, as Senator Cardin was just saying, the acceptance of telehealth. My question about trying to just get enough providers on site in rural America, which is what Senator Crapo talked about. So for Dr. Benton and Dr. Hoover and Ms. Lebarsky, you know, when I was in the state Senate in Wyoming, we were very blessed with additional revenue that we weren't expecting, but we had it. And the commitment we made was to mental health. So we put a lot of financial resources and made a deliberate effort to train, to recruit, and to attract more mental health providers to Wyoming. But in spite of our best efforts, Wyoming and other rural states who are trying to make those similar commitments continue to face huge shortages of all types of mental health providers. So the money was there and we still had the challenge. So can you discuss some solutions related specifically to workforce development that you may believe help improve our ability for us through our mental health facilities so we can attract and maintain staff into rural and sometimes remote areas?
If I may, and I think it's a great question, Senator, I think one of the challenges that occurs within our state of New Hampshire is some of the licensure requirements for professionals. We have a lot of silos with our Board of Mental Health practice of who is allowed to provide licensure supervision for an individual who comes out from their master's degree program. And that at times creates the barriers to who we're able to hire, because if we have to have a specific credentialed professional to provide supervision to that same category of professional, and we don't have them employed at our center, then that candidate no longer looks at us as a place that they want to be employed at. I've talked to colleagues across our state who've lost employees who've went to other states because not only could they make a higher income, but they needed to get the licensure supervision from a particular person. So I think we need to make licensure requirements, create more flexibility on who can provide that supervision in order to attract the staff that are needed to provide the care.
Anyone else?
I'm sorry.
Yes, go right ahead. No, please.
Oh, I was going to say, I'd echo your comments. telehealth also adds another opportunity. It is for training remotely. And so for areas where there's a shortage of providers, we've been able to partner using telehealth to expand skills and to train people. Thinking about Dr. Hoover's comments about task shifting, it's an excellent opportunity for us to provide skills for master's level clinicians, clinicians who need supervision, who may be in another state, for backup consultation across counties, but also by allowing us to continue with licensure across state lines, we can actually also provide support for clinicians in those areas. I also just want to mention a quick win is really educating the people that we already have. So the pediatricians, nurse practitioners, other mental health clinicians, master's level people, TRACE, peer navigators, all of those resources in communities can be utilized to support individuals. We have programs where we're teaching grandmothers to do cognitive behavioral therapy for their anxious grandchildren. And so I think thinking about how we provide care differently could provide us more opportunities for mental health support.
Well, thank you, Dr. Benton. And, to Ms. Lebarsky, to your point of actually I'm working with Senator Smith. It's a bipartisan on people with marriage counselors who do some mental health work as well. And, they're not able to be reimbursed through Medicare and different federal issues too, where they can provide health care. But so it's the siloing by state, but also the federal government sometimes gets in the way as well. And then I know I'm running out of time. We have a commitment to my family to working with families who have lost someone to suicide, what we can do along those lines. We're continuing to look not just to raise awareness, but for best practices. And I know, Dr. Ben, as you're shaking your head, yes, on this, it's a big issue for all of us. So I don't know if you have any final thoughts on that.
Yeah, thank you, Senator, for that question. So, in addition to the suicides, that, over 160,000 young people have lost parents to COVID. And of course, the threat is always not just grief, but traumatic grief. And we're not ready for it. Fortunately, there are quite a few support services available to families who have lost family members to suicide, and for those who are suicide survivors. So the American Foundation for Suicide Prevention is a resource for all families that provide a lot of support and information nationally for families who have experienced that loss. But we have to pay particular attention to those populations who have experienced traumatic grief, because traumatic grief is more closely associated with the onset of depression. And in order to be preventive, we need to develop early interventions and support for youngsters who have lost their parents during COVID, and for individuals who have lost their families to events like suicide and homicide. So thank you for that.
Thank you, Mr. Chair. Thank you, Dr. Thank you, Mr. Chairman.
Thank you, Senator Barrasso, and we are very much going to focus on the best practices that you mentioned. It's a very solid way forward. We're having colleagues come and go, so we're going to have Senator Thune, Senator Bennett, and Senator Langford, and we're going to lock in those three. Okay? Senator Thune.
All right. Thank you, Mr. Chairman, and Senator Crapo, and I appreciate your continued focus on youth mental health, and I appreciate the panel for joining us today. And as I discussed last week, when I talked to parents, teachers, and school administrators across South Dakota, addressing the behavioral health needs of students is a big priority. Dr. Hoover, in your testimony, you mentioned that we need to be looking for more formal partnerships with community behavioral health providers. We have multiple cooperatives in place in my state where schools that are in close enough proximity share a provider, but in some circumstances, distance is a barrier. Do you know of instances where the partnerships you refer to have been formed using telehealth or a combination of in-person and telehealth services? And what are the biggest barriers that schools or school boards encounter in forming these types of partnerships?
Thank you for the question, Senator Thune. Absolutely. We've seen actually tremendous partnerships that rely almost exclusively on telehealth, especially for some of our rural communities. Some of the best examples started in South Carolina several years back, where they had the Medical University of South Carolina providing telehealth services to schools across some of their most rural districts in South Carolina. So we've seen these community behavioral health partnerships with schools through kind of these standard memoranda of understanding with schools and community behavioral health, where sometimes they'll do some on-site support, but really much of the service that's provided is through telehealth. As we've mentioned earlier, some of the real barriers to that are reimbursement. Sometimes schools are not allowable as sites of service, and certain provider types are not allowable, which really does require taking a look at state Medicaid plans and thinking about how to expand school health programs under school Medicaid. And certainly just a lack of awareness of some of the guidelines for how you can set up these partnerships and get reimbursed and supported.
Yeah. Thank you. Doctors Benson and Hoover, Dr. Benson, you want to take this first, but youth mental health in Indian country has been a significant challenge for some time now. Some of the stories are heartbreaking. There was a 2017 Department of Education report that confirmed that kids in public schools on the reservation have a greater risk of behavioral health challenges, including increased risk of suicide. Do you have suggestions for how this committee can help improve access to culturally appropriate care on the reservations, especially how we could grow the workforce there, which is a challenge, finding providers, recruiting, and then being able to retain providers in tribal communities has really been a challenge.
Well, thank you, Senator, for that question. And we too struggle with the challenges that you identified. The Certified Community Behavioral Health Centers are an excellent way to attract clinicians of diverse backgrounds. Clinicians like myself of diverse backgrounds tend to focus on supporting populations that are similar, and so that the chances of working in your community are greater if you're a member of the community. How do we increase providers in those communities? By targeting the communities who need the treatment and identifying individuals in those areas and providing the support needed. So many of the challenges for minority populations relate to finances, high student loan burden, low support for strong academics in the community. Like those are all areas where we would be able to support education, increase interest, and support individuals who would go on to get education in those areas. And some of our focus could be on supporting them in their communities. So many times in academia, we're all familiar with the idea that we recruit people away from their communities, as opposed to providing resources in that community to educate young people through their high schools, their community colleges, training programs, and then diversifying opportunities for support. So in line with Dr. Hoover's comments about task shifting, it's teaching people to provide services at the bachelor's level or other levels that will allow them to expand support for care in their communities.
Thanks.
Just to piggyback on that, in addition to recruiting members within communities and retaining them in their communities to support their communities, also investing in technical assistance and training centers and resources within those communities. A great example of that is the National American Indian Alaska Native Mental Health Technology Transfer Center, which is funded as part of the Substance Abuse Mental Health Services Administration. And then I'll just also add really expanding the federal workforce development programs that we've already mentioned, including loan repayment, but also things like the Minority Fellowship Program and National Health Service Corps can really help in this regard.
And I would add to that some of our national organizations that support children's mental health, the American Academy of Child and Adolescent Psychiatry and other programs actually have minority-focused fellowships to support the development of other mental health professionals. And partnering with the HBCUs for Black families for programs and educational systems that primarily serve Hispanic and Native American youth would be places that we would be able to support development of professionals who remain in those communities.
Okay. Thank you both. Mr. Chairman, my time's expired. Thank you.
Thank you. Senator Bennett is next.
Thank you very much, Mr. Chairman. Can you hear me?
We can.
Great. I really appreciate you and the ranking member for continuing this series of hearings on mental and behavioral health for youth, and we are having a crisis in Colorado. In fact, Colorado's Children's Hospital was the first hospital in the country, I think, to declare a state of emergency in mental health for youth. So I want to thank the witnesses for being here to testify, and particularly grateful for having Mr. Terrell here advocating on behalf of his peers and his generations. And I've got a second question for him, but let me start first with this. On reimbursement and prevention. Last week, the Surgeon General was here, and I raised the importance of reimbursement for mental and behavioral health services, something our committee has jurisdiction over through CMS. And while I was going through your testimony, a common theme was that we need improved reimbursement for services across the continuum of care and meeting youth where they are. And I wholeheartedly agree with this. So I would ask Dr. Benton first, maybe, what kind of services should be reimbursed by Medicare, Medicaid, or private payers that are not usually covered, and what services need increased reimbursement? Can you highlight where you believe reimbursement parity is failing the American people? Dr. Benton, let's start with you and see, and anybody else that would like to add after that.
Yeah, well, thank you. Thank you, Senator, for that question. So currently, most of the early childhood services are not reimbursed. So there are services that are required in the medical and mental health setting that are comprehensive services that should start from birth through adulthood. But services that don't necessarily have a psychiatric diagnosis attached are frequently not reimbursed. So, for example, if a mother who was having difficulties attaching or parenting her newborn, those services are not necessarily reimbursed by traditional mental health providers. Furthermore, for pediatricians, who are typically the best people to identify early childhood problems because children have frequent visits in the first year of life, they're not reimbursed for the time it takes to provide the level of counseling that's needed for new parents who have new infants. And so if we targeted the reimbursement for those services, the pediatricians would be allowed to do their jobs. The nurse practitioners could do their jobs. People who are working with young children could do their jobs. And that for young children who are not yet impaired by a mental health condition, preventive services would allow families to seek that care in appropriate facilities, and reimbursement could occur at the same time. So I think the early childhood services currently are under reimbursed for the ones that are available. And for children who don't necessarily have a mental health condition already, they're not able to seek the services they need and get the payment that's required.
Thank you for that answer. I very much appreciate it. Let me ask my second question, because I know time is short. As I mentioned, so important to have a young person here, Mr. Chairman. Thank you for doing that, to give their perspective on the crisis. We should think about, I think, including young people here more often. As you know, the National Suicide Prevention Lifeline will be transitioned to 988 by July 16th, 2022. In Colorado, we are having, I'm sad to say, an epidemic of teenage suicide. The numbers are just staggering. And Senator Corn and I have introduced legislation to increase funding to make sure that this transition to the prevention lifeline is successful. And we're thinking about how to incorporate texting and connect individuals with services they call or text in to make it more effective. And I just wonder, Mr. Terrell, could you share your thoughts on all of this and what types of resources and improvements we should be thinking about that would be most meaningful in your mind?
Yeah, thank you, Mr. Bennett. That's a great question, and I think one that takes a lot of conversation to actually get to, a good policy solution. But right, statistics show that teens talk to their friends more than anything. So the more that we can empower and equip youth with the skills needed to support their friends in crisis, I think the more we'll see kind of general health and well-being trends for youth increased. All Youthline volunteers get the opportunity to go through pretty extensive training. So I personally went through 63 hours of training where I got safe talk, suicide alertness, applied suicide intervention skills training, youth mental health first aid, and QPR. And those are all master's levels, master kind of clinician level trainings. And so we know that youth have the capacity to take on this role as supporters in their communities. And so, like I mentioned in my testimony, I think the idea of a national youth line where we expand across the country and we really invite youth from all different communities to be involved in this process and help destigmatize the conversation around mental health would be really helpful. And I think I would be really happy to connect with you later on that.
Great.
Yeah.
I will take you up on that. I know the chairman has your contact information, so I will track you down, and I very much appreciate it. Thanks, Mr. Chairman. I know I'm out of time.
Thank you for all your leadership, Senator Bennett. The next two are Senator Lankford and Senator Brown.
Mr. Chairman, thank you. All of our witnesses, thanks for being here as well and talking through this important conversation. Dr. Benton, I do want to be able to start with you. For individuals within a school, whether it be a school counselor or a teacher that may discover some mental health challenges that a child would have, are there any barriers to communicating right now in the system, whether it be HIPAA issues or legal issues or just process issues with that individual communicating with parents, other school counselors or engagement, law enforcement, or outside medical entities? Are there barriers that are there that we need to be aware of?
Yeah, thank you, Senator Lankford, for that question. And I'll start my comments and defer to Dr. Hoover, who has more expertise. But yes, there are barriers currently. So you're not able to have a conversation between a mental health clinician who actually may be caring for a youngster and his teacher or school counselors without permission, either through FERPA for the school and for HIPAA for the provider. And those two groups don't often communicate with each other, posing barriers for care. It creates a situation where for teachers and for counselors that addressing mental health concerns may require sending that young person off to an emergency department in order to get the care that they need. So yes, there are definitely barriers in communication related to privacy laws. Dr. Hoover, I didn't know if you had further comments.
Agreed. The good news is that many school systems in partnership with behavioral health systems have really navigated those HIPAA, FERPA privacy issues. For example, by initially sending paperwork home to families, even at the start of school years, to inquire about whether they are willing to give consent for communication to occur when in the best interest of the child's health and well-being and academic success, allowing for some of that communication to occur, again, with privacy in mind, but also supporting academics. The other area that I would say is critical is really expanding data systems that allow for the seamless sharing of data between health and education sectors. And that has been done well in several districts and states. So there are good examples. It's just not widespread enough yet.
So are there needs that we need to have as far as change in statute to allow more of that communication to occur at this point? Or do you think the statute is appropriate? We just need additional permissions and access points?
Yes.
Good question. I mean, frankly, I think that technical assistance and training and just raising awareness that HIPAA and FERPA do not have to be barriers to communication as long as you have family engagement and consent. That may be enough. It has been enough in several communities to actually bridge the divide here.
But I will say there are also state laws that govern who actually can release information. And so that also becomes a barrier because sometimes the young person actually has control over that information and the parents don't. And so, I think that in some places it works, but I think greater guidance and standardization of these processes would help all of the communities. Dr. Liborski, I know that this must come up for you often.
It does come up for us quite a bit, but I think the training involved, I think making sure that schools and the mental health providers. So when I think about our examples of where we're integrated in over 25 schools in our region providing mental health care, where we're delivering that for our staff, it's working collaboratively with the school, with the family system, parent, guardian, and caregiver to make sure everybody's involved. I think honestly, where we see this as a barrier, where it comes up as a challenge is when there's failure to communicate with the family system about the youth's need and making sure in advance of providing care or suggesting care that those conversations are happening as well. So I think that's where training is a big component.
Yeah, I would agree. In Oklahoma, we just had a law passed within our state that has allowed for training for everyone within the school on suicide prevention. We have 13,000 people in schools that have been trained just in the last couple of years just to be able to help with suicide prevention and to be able to know how to engage and the next steps on that. So in our state, we've been very forward leaning to be able to do what we can to be able to help. Mr. Chairman, a conversation that we could have at some point to be able to have on this whole issue as well is the whys and the prevention behind the scenes. We always, on the Finance Committee, we look at it and say, what can we do with more Medicare and Medicaid and what the tools that we have. the next big question behind it is, as we watch suicide rates rise 57% among teenagers and young adults over just the last 15 years, as we watch all these other things occur, to ask the practical question of why. Our nation has been through difficult challenges in the past, World War II, Great Depression, all these other things. Why are we watching some of the rise now? What's happening in technology? What's happening in the engagement? And for myself personally, I've worked with students 22 years before I came to Congress, working with middle school and high school students. This is an area I've worked with extensively, and I think there are a lot of questions that we've not asked the one behind the issue, not just how do we fix it, why are we seeing the rapid rise, and what do we need to be able to do? The issue of technology and telehealth is really important, but there's another angle with technology as well that's driving comparisons among individuals that's pretty toxic. And so we've got to be able to help resolve some of these issues in the days ahead as well.
Thank you, Senator Langford. Very important point with respect to suicide. And Senator Barrasso took note of how important it was as well. This is an area he's going to focus on. So I think this will be another opportunity for both sides to work together. And I appreciate both you and Senator Barrasso bringing it up. Senator Brown is next.
Thank you, Chairman Wyden. Mr. Chairman, I asked that written testimony offered by the Director of Pediatric Psychiatry and Psychology at Akron Children's Hospital be included in the record for today's hearing.
Without objection, so ordered.
Thank you, Mr. Chairman. Dr. Benton, as you probably recall from your time some time ago spent in my state for medical school, Ohio has excellent children's hospitals in pretty much almost every part of the state: Cincinnati Children's, Dayton Children's, nationwide in Columbus, Akron Children's, Rainbow Children's, and Northeast Ohio, home to several outstanding pediatric, as you know, pediatric, not podiatric, centers of excellence. Despite the resources our state has, Ohio's children and health workers are still struggling during this pediatric mental health crisis. Ohio's, just like counterparts across the country, our children's hospitals need our support to rise to meet the needs of children and adolescents and address this serious public health crisis. Experts tell me that one of the biggest challenges is meeting the needs of multi-system youth. Could you talk about action, Dr. Benton, actions Congress can take to better support children's hospitals in their work to support youth served by multiple systems? For example, those who are in foster care or justice involved or have a developmental disability in addition to a mental health diagnosis. And how can we ensure effective communications between and among juvenile justice and child welfare systems to best support these children who so often just get left out?
Well, thank you, Senator Brown, for that question. And just for you to know, Cincinnati is my hometown, so I am an Ohioan. And so I just wanted to say that that's an excellent question and one of the greatest challenges that we face in mental health care now. So that the systems in which children exist, as you've highlighted, childcare, education, juvenile justice, foster care, and others have little or no collaboration. And systems are actually not in place to facilitate that collaboration. The attempts to coordinate it are either baffled by bureaucratic challenges or unwillingness to acknowledge that the systems are actually connected. And so what would be required is a focus on requirements among those organizations, that there's better coordination. We talk often about case management, as a broad term, but those individuals are often the ones who are facilitating communication between organizations that do parallel work, caring for the same kids, but don't necessarily have an effective means for coordination. Some of the data shows us pretty clearly that about 50 to 75% of over the 2 million children who are adolescents in juvenile detention actually have had limited mental health treatment or limited mental health support. And so, essentially, communicating expectations that those agencies collaborate around the care of the same kids by establishing systems that facilitate that could go a long way. For children's hospitals, we struggle at times with children who are admitted to the children's hospital with a medical condition and a mental health condition. The medical condition is resolved. The mental health system issues are resolving, yet they're waiting for placement in foster care, sometimes remaining in hospitals for up to a year. And at that juncture, payers are not accountable. The agency who acts as the parent is not accountable. And then the hospital is accountable for providing all of those services that require multi-agency collaboration. Expectations of accountability for those agencies who are often managed by federal governments and states would be essential for being responsible for coordinating care of young people.
Thanks, Dr. Benton. I have a question that I would like all of you to answer, but very briefly, because my time is short and the chair is always tolerant, but his patience probably wears thin. I asked the Surgeon General last week how we better integrate mental health services with our schools. And my question to each of you, based on actually Dr. Benton's hometown, there is a community school in Cincinnati, Euler, which has become a bit of a template for the whole country, the whole state and the whole country. Briefly describe, if you had a chance to offer a suggestion, one thing schools can do to leverage relationships with community partners, state or local health departments, hospital service centers, whatever. Just give one simple recommendation of what we can do better, schools can do better to leverage that. Dr. Hoover, you want to start, and then Ms. Lebarsky, and then Trace, and then finish with Dr. Benton briefly. Thank you.
Happy to. Thank you, Senator Brown, and familiar with the school in the Cincinnati area that does this well, and as you said, serves as a model for the nation. So one simple thing that can be done, there are good templates for memoranda of understanding and requests for proposals that can go out to districts to solicit community behavioral health partners to come in and engage in school behavioral health provider services in the schools. Instead of it just being kind of a hodgepodge of services, it can be organized through a request for proposals process with standardized memoranda of understanding with community behavioral health.
Thank you. Ms. Lebarsky next, and then Trace.
Sure. And first of all, I'd say go Bearcats. As a graduate of the University of Cincinnati, this is something we've done really well in our community. It's really establishing not only those agreements of understanding, but it's really finding a standardized assessment tool that schools will feel comfortable utilizing in order to be able to do that screening, to pass it on to the behavioral health care, whether it's utilizing our mobile crisis team at the center for a youth who's going into crisis in the school setting, or being accepting of the behavioral and mental health supports that our staff can provide. So I think using some standardized screenings that school districts feel comfortable with is one step in that direction as well.
Thank you, Trace.
Yeah, I also think part of the big reason is we need to invite youth and kind of see what they actually want and what resources would be helpful for them, because it's one thing to offer resources and it's another for teens to actually access them. So when we conduct needs assessments and really see what works for youth, I think we'll experience better outcomes in that regard.
Well said. Thanks, Dr. Benton. Close with you. Thank you, Mr. Chairman. Go ahead.
Thank you. I just want to say that I support all of those things that were just mentioned and putting a system in place to make sure those things can happen easily and accessibly.
Thanks, Mr. Chairman.
Thank you, Senator Brown, and thank you for having brought me to Ohio over the years to meet with a number of your healthcare providers, and we've seen his advocacy in action. Next is Senator Casey.
Mr. Chairman, thanks very much. In light of all the references to Ohio that Senator Brown made possible, I want to make sure we emphasize that Dr. Benton is now at the Children's Hospital of Philadelphia, so we're honored that she settled, at least most recently, in Pennsylvania. But Dr. Benton, I wanted to start with you and start with a critically important program that so many Americans know the name of, and so many Americans have a sense of what it does, but maybe none of us fully appreciate how important it is, and that's Medicaid. I've often said that Medicaid often tells us who we are as a nation, but maybe more importantly, tells us whom we value, whether it's children or people with disabilities, including children, older Americans who need skilled care in nursing homes paid for by Medicaid. We also know that Medicaid is the largest insurer for children, but it unfortunately pays significantly lower Medicaid rates and commercial rates, which has terrible consequences often for the pediatric health workforce and equitable access to care. I know in your testimony you highlighted how low reimbursement rates in mental health care access, the concerns that you have about that, particularly with regard to underserved communities. On page 7 of your testimony, you said, quote, better reimbursement for mental health services in Medicaid would make it possible to resource the full continuum of care our children and youth need, unquote. So the additional years to specialize in child psychiatry are not financially rewarded in the current payment structure with Medicaid, where a provider could earn more providing care to adults. So this makes it hard for a child-focused provider, particularly challenging for families covered by Medicaid. So how would aligning Medicaid reimbursement for children's mental health services with Medicare levels impact kids' access to care?
Well, thank you for that question, Senator Casey. So aligning those incentives would increase the reimbursement for Medicaid at a rate that would be more acceptable to most institutions. And that's key. Community mental health centers really struggle to meet the needs of young people based on reimbursement. Children's hospitals really struggle to meet the care for children with reimbursement. And in addition to that, lower pay for providers is discouraging for subspecialists, not only to serve the populations of young people, but to even train to serve the populations of young people. General psychiatry training takes 4 years. Child psychiatry training takes 6 years, 6 years of accumulated debt, which has resulted in mental health professionals opting out of payment structures for reimbursement for mental health care. And so increasing the Medicaid reimbursement rates to be on par with Medicare and medical rates would increase our opportunity to address the gaps in the continuum. So there are areas in the United States where there are no services on any continuum available to young people. Medicaid reimbursement would allow us to develop a full continuum of care, not just emergency and inpatient crisis services, but ambulatory services, home-based services, day hospitals, intensive outpatient programs where young people could be with their families and be at home getting the level of services that they need. And so the current Medicaid reimbursement rates impact all of those things, and increasing them to be better, which would be consistent with Medicare rates, would allow us to provide the services that we need and would allow us to encourage young people to pursue careers where they provided mental health care for young people.
Doctor, thanks very much. I might submit an additional question for the record for Dr. Benton, and I'll give back time, but I did want to thank again the panel for their testimony today. In particular, I wanted to thank Mr. Terrell for coming forward on behalf of his generation, and I hope there are other opportunities for us to engage. But thanks very much, Mr. Chairman.
Thank you, Senator Casey. Trace, you are now clearly the people's choice because both Democrats and Republicans are praising you to the skies, and it is richly deserved. Okay, Senator Hassan, we welcome you and all your good work.
Well, thanks so much, Mr. Chair, and thanks to you and the ranking member again for this hearing. And I will add my thanks to Trace as well, and also just note that the good news for America is Trace is representative of his generation, and there are lots of wonderful young people in my state, and I know across the country, really advocating for the mental health of their peers. And in New Hampshire, it's very true. I actually had a 9-year-old look at me one day and say, "What are you doing about mental health, Senator?" And so thank you all for just being the kind of advocates that make a difference. I want to touch on a few topics that have been discussed, but I want to drill down a little bit. Let me start with Ms. Lebarsky. In New Hampshire, a small pool of mental health providers is working overtime to help the growing number of children with mental health needs, and it's just not sustainable, and we've all talked about that. Following up on the testimony you've already given, what are the main causes for this mental health workforce shortage in New Hampshire, and what can we do to help alleviate the crisis?
Thank you very much, Senator Hassan. I think we've all spoken to this very well this morning and now going into the afternoon. It's really the ability for centers to reimburse their staff at a rate that they can survive on. When we look at the cost of living, and we just spoke about Medicaid rates being significantly low. So we have a workforce that's burdened because other providers in our community and within our state and country who could accept Medicaid and choose not to because reimbursement is so low, then we burden those providers who are accepting of it. but the facilities themselves can't reimburse to sustain the staff long term. We hear that all the time in our exit interviews.
Okay, thank you. Dr. Hoover, you've also touched on this, but I want to drill down on mental health in schools. Schools are often the only place that children can receive mental health care, but many schools lack the personnel and infrastructure to meet demand. What are the barriers that schools face, particularly when it comes to recruiting and retaining mental health providers?
Thank you, Senator Hassan, for your leadership on this and for the question. We know that we suffer the same issues that the general workforce shortage reflects as well. So simply put, we don't have enough providers, they're not trained well enough, and they're not paid enough. And what I mean by that really is that not only do we have shortages in workforce coming into the field, but they don't really represent the populations being served in terms of race, ethnicity, language spoken. So we have to do a better job of recruiting and retaining diverse and representative providers. They're not trained well enough. And what I mean by that is that we have many mental health providers, not enough, but many, but they're not trained to specialize in child and adolescent mental health, nor to work in schools. And as we've already said, they're not paid well enough. So reimbursement rates are a large issue. Again, I'd go back to that we also need to re-envision how we think about our mental health workforce and think about all of the other professionals and even non-professionals that can do this work well. I love the idea of a grandmother providing cognitive behavioral therapy to grandchildren, as our child psychologist or child psychiatrist, but Dr. Benton mentioned, but also our peer and family navigators. We need to be doing more to invest in that workforce as a way to support mental health.
Yeah, thank you. And I know in New Hampshire, peer-to-peer training and student empowerment has been really, really critical as well. Ms. Lebarsky, mental health resources need to meet children where they are. And during the school year, that's in the classroom, but mental health doesn't end when the school year does. So you've led an innovative program based on that insight, working with the Community Behavioral Health Association and the state government. Your clinic offered mental health training for camp counselors and provided on-site resources at summer camps throughout the state. So kind of following up on where we were just going with Dr. Hoover, what was the impact of this program and how can we scale up this model so that more children have support year-round?
So I was so excited about this program. Our Commissioner of Education labeled it Rekindling Curiosity, and it was really a means to tackle the mental health needs of students after being isolated from their peers. So we began last summer by training summer camp staff in recreation programs and camps across our state, and we're allowed to carry that funding into the school year. So we've continued to utilize it to provide professional development days to educators, to do youth mental health first aid training for educators. I have staff right now that are planning for February vacation week here in New Hampshire to go out and support young people to be maintained in camp settings or recreation settings that may otherwise not be able to be maintained because of their behavioral health needs. So rather than excluding them or expelling them from these programs, we have staff going on site, supporting the counselors and the youth to stay with their peers and really get a meaningful camp or recreation experience.
Well, thank you so much. It's a great program. Thank you for everything you're doing for New Hampshire. We really, really appreciate you. And last thing, I'm going to follow up, Dr. Benton, with a question on the record for you. I'm particularly concerned about the isolation of children who are immunocompromised right now during the pandemic and whether there are specific ways we can help those kids. So I'll follow up with you on that. Thank you all. What an excellent panel.
Thank you, Senator Hassan. And that last question is particularly important and hasn't gotten enough attention, and thank you for asking it. Senator Cortez Masto is next, and then Senator Young, and we will wrap up one of the best hearings I've certainly been to. Senator Cortez Masto.
Mr. Chairman, I agree. I just have to thank the witnesses for being here. It has been a long morning, but a fruitful discussion. I cannot thank Mr. Chairman, the ranking member of the committee, so much for having this hearing. You know, let me just say, I hear every day from Nevadans that one of the most critical ways we can protect kids' mental health is by keeping our schools open. And that's one of the reasons why I've been working to make sure that our schools stay open, have what they need to keep and help our kids in the classroom and provide important services and support that we're talking about today. One of the areas I'm going to start, Ms. Lebarsky, with you, though, is stigma. My goal has been to tear down that barrier and do away with stigma. Listen, I think that anybody who goes and talks to a doctor about their physical health and has a funding source for that, that should be on par with mental health. That it should be the same thing. You can walk in, get help for your mental health, and it should be funded, and there should be no stigma associated with that. But Ms. Lebarski, let me ask you, can you talk about the impact that telehealth has had there? Have you seen patients more inclined to follow through on the course of treatment through telehealth? And does that knock down some of that stigma associated with receiving services for mental health?
Absolutely, Senator. Thank you for your question. And when I hear your question, it makes me think of a young lady I worked with years ago. And at the conclusion in every one of our sessions, regardless of the weather, she'd pull over a hooded sweatshirt, sunglasses, and a hat and say, I don't want anybody to see me walking out of this building with the giant sign that said mental health center out front. So for a youth like her, having that option to sit in the comfort of her home behind a screen and nobody knowing that she was accessing care with me, I think was a complete game changer for many of the youth in our world. So yes, I think the addition of telehealth not only knocked down barriers to getting care, but eliminating the stigma that many youth and families see around mental health care.
Thank you. And one of the things that everybody's been talking about, I so agree, is access to the resources, the funding to support your services when you seek those for mental health. That's one of the reasons why I've partnered with Senator Daines on legislation that actually enables families with high deductible health plans to access no-cost telehealth services before they meet their deductible. What I find is that's often a barrier as well, is just accessing the payment plans, resources to pay for these services. So thank you. Let me ask you this, Mr. Terrell, because I saw you nodding your head. Based on your work with Youthline, can you talk a little bit about the value that peer-to-peer relationships have as well in helping kids feel less isolated and more willing to seek services for their mental health?
Absolutely. Thank you, Senator. I think that's a really great question because part of the reason that Youthline works so well is that it is peer-to-peer. And we know from statistics that youth are more likely to turn to their friends than anyone else. So when we foster that natural partnership, right, it really helps to destigmatize mental health in that regard. But I also think Youthline works so well because it's a crisis support service. And there's a difference in that, right? So a lot of time when we talk about mental health, there's this conception that you only have to be suicidal or experiencing kind of acute high stress situations. When that's not true, right? We know that mental health encompasses a lot of things. And so when we talk about support, Youthline is one of the only crisis lines in the country that offers teens the ability to talk about their mental health struggles without the fear of being like the problem being too small or too big. We really emphasize that there is no problem that is too big or too small. And when we talk about mental health, we really need to recognize that. And just something that my supervisor always says is that we teach young people to call 911 when they're in like emergency settings. And unfortunately, that permeates over to how we like the National Suicide Prevention Line and like 988. So the sooner we can teach children that it's okay to call a crisis line, that it's okay to reach out for support for mental health, I think the more better we'll see this issue become in the future.
And thank you. And I couldn't agree more. I just so appreciate the comments today on the need for more robust crisis services for kids. The chairman and I have worked on this. I truly believe that when we are in crisis mode or they are in crisis mode, there should be a place they call. And it's not law enforcement always responding. It's a mobile crisis intervention unit. That's why the chairman knows this is the CAHOOTS bill that he and I worked on together is based on the best practices in Oregon and his state. And I think really the focus for me has been addressing that crisis mode and bringing those essential services at that time. You know, Senator Cornyn and I have introduced legislation that would actually set flexible standards for crisis services and, again, provide insurance coverage, which we see is lacking as well. So I know my time is up. I cannot thank you so much for this conversation. Mr. Chairman, I'm hoping that with telehealth services and so many other areas that we have to focus on, we are actually going to implement more work around bringing essential mental health services to so many in our communities. Thank you again, everyone.
Well, I thank my colleague for her leadership, and you made mention of the fact that working together, we were able to put together a model that brings together mental health folks and law enforcement folks. And so if you go off and you talk to Senator Booker, He's really interested in the program. If you go off and talk to Senator Scott, which I've done repeatedly, I know my colleague has, he's very interested in the program. So the Finance Committee is really trying, as you suggest, break some new ground and fill in these gaps. And I just want to thank my colleague for all her leadership on these issues. She has just been invaluable, and I thank her. Senator Young, you're next.
Thank you, Chairman. And I want to thank all of our panelists today. Such an important hearing. While we may not fully understand the pandemic's long-term impact on America's youth, early data is alarming, especially to this father of 4 teens. According to the Indiana Youth Institute, teen suicide deaths in my state increased 73% in 2020 compared to 2019, while teen deaths by overdoses increased 66% from the previous year. Dr. Hoover, what additional research do you believe is needed to better understand these trends and identify effective evidence-based interventions?
Thank you, Senator Young, for that important question and just for raising awareness again about the dire statistics that we're seeing, both with respect to mental health and suicide and also substance use. We can't forget substance use in this conversation of mental health, so I appreciate you lifting that issue up. With respect to research, we are fortunate that we're seeing greater investments in research in both mental health prevention and intervention and also in the substance use arena. So we would certainly urge Congress to continue supporting research in those areas. Some of the areas that we think we need more investment would be novel treatments specific to certain populations, racial ethnic populations, immigrant populations, different student populations in rural versus suburban versus urban settings. So really thinking about how do we develop and implement interventions that are specific and tailored to the community. We also need to understand who is actually thriving or succeeding in these environments of adversity, trauma, and stress. So often the research looks at those who are suffering and how we can provide treatment, but it's really important that we also look to research to understand what are the protective factors, whether it's individual protective factors or community factors that actually promote thriving and flourishing, and how can we bolster those through school-based interventions and other community interventions.
No, thank you. That's quite helpful. I would open this up to our panel. If you can keep your response really brief, if you have one, panelists. What steps can the federal government take right now to help reach at-risk teens at their individual moment of crisis?
I have two brief suggestions. One would be educating our frontline providers right now around addressing mental health challenges. And the second is setting up more crisis programs, mobile crisis services that can go into families' homes and their environments and provide crisis intervention.
I would add to that, Senator, having worked with school educators recently, they're feeling like mental health is walking through their classroom doors every day. So I think we need to afford educators the professional development time and give them that fundamental training in something like youth mental health first aid so they can recognize the signs and symptoms and know how to braid that young person over to the next level of mental health care that they need.
I think we should also make sure that this isn't the last conversation that we have about teen mental health. As a teen, we need you to continue to have these conversations and to continue to involve us in this work. We deserve a seat at the table, and I think that's it.
Trace, I think that's really important. I mean, all our solutions need to be grounded in the realities of individual human beings, folks on the front line of this crisis, right? Which is our teens. Dr. Benton, in your testimony, you discussed the web of systems beyond healthcare that impact the well-being of children and adolescents, such as foster care, education, food programs, and how these systems rarely collaborate, or when they try, are foiled by bureaucratic barriers or an unwillingness to acknowledge their interconnected nature. Research has indeed shown that addressing these types of factors, which we often refer to as social determinants of health, can positively impact the health and well-being of the most vulnerable Americans, including our nation's youth. Doctor, how can we better leverage existing programs to help children and their families and address the barriers to coordination between mental health and social services programs?
Well, thank you for that question, Senator. One of the things that we could do right now is demand a higher level of accountability for agencies responsible for coordinating these services. And I'll just take child welfare as an example. So child welfare, as the parent or acting in loco parentis for any child in their custody, is responsible for coordinating school, mental health, medical care, and all the services. And I'm assuming there are barriers to them doing that because it's challenging to make that happen. But I think for those agencies, there needs to be clarity and reinforcement around expectations that coordination happens. For where I sit, it's the greatest challenge that I am facing in the care for young people at the Children's Hospital right now really is the child welfare system.
So you need accountability metrics, and you need to identify who is responsible for achieving those metrics. Is that accurate?
You've summed it up well. Thank you.
All right. Thank you much. Chairman?
I thank my colleague, and there's a vote on the floor, so I'm going to have to be very brief, but I just want to say this has been one terrific panel. I mean, each of you have really made the case that Trace started talking about 2.5 hours ago. Trace Terrell of Lapine, Oregon, basically said, look, what we got to do in America, and we students are starting it, is mobilize, get active and mobilize for real reforms of American healthcare. And each of our witnesses, Trace, in their own way, sort of reaffirmed what you're saying. And so the first thing I want to say is, Trace, we're going to dedicate our efforts to mobilizing the Congress for these fundamental reforms the way you've said you're mobilizing young people. So that's number one. Number two is the message of so many young people getting lost in the system is another extraordinary takeaway from today's hearing. I noted in your testimony, you said that at your school, with respect to referrals to mental health services, 80% of them went nowhere. And what was so striking to me, Trace, is a number of our experts from around the country said, hey, Trace is speaking for his school, but by the way, that's pretty much the pattern around the country. It might not be 80%, but we're just losing too many young people. And by the way, that's what Dr. Murthy said last week, is we're just losing too many young people. So I'm going to close with this, and we're going to dedicate this to you, Trace, because this is a hearing on young people. I want to thank all our experts for being so helpful. Trace, I want you to know, right at the heart of our work is our judgment, Democrats and Republicans, that our country is better than this. We are better than this. And as we go forward, you are going to have a seat at the table. You're going to have a seat at the table. We're going to be reaching out to young people across the country, and we are going to stay at our work until we find some real solutions to the issues we've talked about. Big thanks to everybody. Just a terrific hearing, one of the best I've been part of. And I want to thank all of you because you've really laid out the path that we've got to follow, and we're determined to do it. Thank you all. The Finance Committee is adjourned.